surgery and trust-appointed doctors in cardiothoracic surgery. This course is going to run all afternoon, and we have a fantastic faculty who are going to address different issues related to both groups, the problems that you might be facing, and how to put forward some solutions for these problems. I would ask you to all please mute yourselves during the talks to prevent interference, and to put your questions in the chat as we go along, which will be answered after each talk. But you're also very welcome to show yourself, unmute yourself at the end of a talk, and put forward your questions in person if you wish to. But use the chat as we go along if you have any questions and clarifications you want to seek from our speakers. So without further ado, I would like to introduce our first speaker, who doesn't need much introduction. Mr. Murjani, who is the Honorary Secretary of the SCTS, and who is a very active member of the SCTS looking at equality and diversity, and has been a great supporter of mentorship, the mentorship concept as it has been developed in the last year or so. So I would like to ask you kindly to share your slides, Darren, and take over. Thank you.
Mahmoud, thank you so much. It's a real pleasure actually to be talking at this course, and this is a big part of what our equality, diversity, inclusion strategy is moving forward. And it's great to get some of the mentees and the mentors together so that we can introduce everyone to each other, and also get an understanding of what we're trying to do with mentoring and trying to develop an inclusive and diverse cardiothoracic community. So it's really exciting that we managed to get this first iteration of our course together. So thank you for joining us today, and I'd like to just sort of talk you through what our equality and diversity and inclusion strategy is for the society, and then specific logistics regarding the mentorship program itself. So as Mahmoud mentioned, for those of you who don't know me, I'm a consultant cardiac surgeon at Papworth Hospital in Cambridge. I'm also the co-chair of the Equality, Diversity, Inclusion Working Group for the Society, and also the Honorary Secretary of the Society. This presentation and this sort of our Equality, Diversity and Strategy, Inclusion Strategy is really timely actually, with two recent publications. The one on the right is from the government, from the Commission on Race and Ethnic Disparities, produced by Tony Sewell, and highlighted some issues that are going on in our society around us, not just in cardiothoracic surgery. And then the report on the left is one produced by Baroness Helena Kennedy, which is looking at issues regarding equality, diversity and inclusion in surgery in particular, and obviously in the Royal College of Surgeons in London. So although equality, diversity, inclusion means a lot of things to a lot of people related to their experiences or their backgrounds, I thought it was important for everyone to understand what equality, diversity, inclusion means to us within the society. So we'll set the context and the backdrop of what we are trying to achieve with our strategy and also with our mentoring program. So equality represents the rights of different groups of people to have similar position and receive the same treatment. Diversity represents the involvement of different types of people in a group or organization. And inclusion, importantly, represents honoring, respecting, embracing, and valuing the unique contributions and perspectives of all individuals and removing barriers to individual success. And whilst understanding it means different things to different people, I think it's important for us to understand the general principles of what equality, diversity, and inclusion are. So why bother? What are the benefits of us trying to develop this strategy? It's not only the right thing to do morally, but it also has benefits. Studies have shown that it improves vastly the well-being of the staff delivering care to patients undergoing cardiothoracic surgery, but it also improves the quality of care that is delivered, as well as improving patient satisfaction for those undergoing cardiothoracic surgery or other aspects of clinical care. Importantly, there's also the concept of cognitive diversity. By developing an inclusive and diverse workforce, you get people from different backgrounds bringing different ideas through innovation and different technologies that we bring in. And finally, having a diverse specialty will enhance the reputation of the specialty and also attract highly motivated individuals that can see themselves working in that specialty. So it's something that we need to strive for and push further forward. So what are the barriers? A number of surveys have been done, particularly in America, that looked at why achieving equality and diversity and inclusion is difficult in specialties such as cardiothoracic surgery. The first thing is work-life balance, and that pertains to both men and women. Underrepresentation of mentors and role models. Studies have shown that actually for medical students to be attracted to a specialty, they'll be twice as likely to choose a specialty if they could see role models or individuals that were like themselves from their background that they could relate to. So it's really important for us to have the right role models and mentors, and hence one of the reasons for developing the mentorship courses that you're all on today. Another reason why some of these concepts haven't been developed is a lack of exposure from those from a diverse background into specialties such as cardiothoracic surgery. The concept of unconscious bias, where we have developed perceptions or ideas of certain groups of people that is outside our own consciousness and how we react to them. And it's important that we understand what those are and therefore can address them. And similarly, nepotism, where friends and families, friends or family members or people with like-minded individuals are preferred over people of a different background. And this precludes us bringing in introducing a diverse workforce. So it's important to understand some of these barriers before we move on to try and tackle them. Trying to tackle this is a complex issue. It is a complex issue because it involves the whole society around us. And so it's important to have a coordinated multi-level approach, not only within cardiothoracic surgery, but in society in general, because there are different initiatives that are going on in society at the moment that we can learn from in the cardiothoracic community. But it is up to organizations such as the SCTS to develop, to have a leadership role in developing a vision on how to create a diverse workforce and an inclusive environment. And this needs to be then disseminated down at the institution level to trusts and medical schools, where they share the same vision to try and provide the right environment for this to flourish. But importantly, it's also incumbent on every individual to take part in this process. So where we have the opportunity to interact with our multidisciplinary team through clinical practice, through education, through patients, that we understand our own role in this and also our own unconscious biases, so that we can try and provide a better environment for all of us to work in. It's important to understand that these different levels interact with each other, and we need to have a coordinated approach for us to make substantial changes. So although trying to make big changes related to quality, diversity and inclusion can be daunting, it is important that we and the society take on these challenges. So as a society, we've set out a number of initiatives that we've already started or will be initiating over the next few months to see how we can improve the environment around us. The first is to get an understanding of what is going on in cardiothoracic surgery. So we've set out a equality, diversity, inclusion survey, which concluded at the end of May. We've had 214 responses, so about over 30% of the workforce, which as a percentage may not sound great, but if you compare a lot of previous studies, such as the one done by the AATS in America, which only had a 9.8% response rate, I think we've done very well. And it's given us some ideas, and we'll be presenting the results of the survey later in the year. But it'll give us a baseline demographics of the cardiothoracic workforce, the issues that exist in cardiothoracic, and more importantly, how members feel the society can contribute to the agenda and making things better. So the first part of the strategy that we're going to be introducing is increasing opportunities to encourage those from all backgrounds to consider cardiothoracic surgery as a career. We've done this through the student engagement events that we've been running over the past few years, where in particular hosting medical schools are encouraged to reach out to schools from areas of social deprivation to attract sixth formers to see cardiothoracic surgery as a potential career. We also have an active involvement in careers fairs, such as through the BMA, ASIT, and other organisations, and the Royal Society of Medicine. There's also the bursaries and international travelling fellowships to encourage individuals such as medical students to go out and experience cardiothoracic surgery and increase the reach or the potential career path for those. And finally, the work experience programs, the student immersion programs that we currently run that exist in a few centres around the country, and we're trying to make sure that exists in all cardiothoracic units in the country, where sixth formers, particularly from areas of social deprivation, have the opportunity to spend 2 weeks in cardiothoracic unit and observe cardiothoracic surgery, and what for many is a life-changing experience and will therefore allow them to see cardiothoracic surgery as a potential career choice. The next two strategies relate to why a lot of you are here today. So the next part is to increase opportunities and provide support for career progression for women in cardiothoracic surgery. And the first tenet of that strategy was to set up the Women in Cardiothoracic Surgery Mentoring Program. I'll talk about the principles of the mentorship program in a couple of slides' time, but it was just to allow individuals that feel that they wanted an idea of where the challenges are for women in cardiothoracic surgery and trust-appointed doctors and how we can support them on that career path. And on top of that, we'll be running networking events for individuals to get together. And also we've set up the Women in Cardiothoracic Surgery Working Group, where individuals can try, where we've set up, I think, about 12 or 14 members of the working group that can try and allow us as a society to try and further increase the support and development of women in cardiothoracic surgery, so we can get a better idea of some of the challenges and try and provide a network or a support to try and progress some of those ideas. Similarly, for trust-appointed doctors, we've set up the mentorship program. We're also enhancing the education program. We understand there is a discrepancy between the education program provided for the nationally appointed trainees and the trust-appointed trainees, and we want to try and redress that balance. Some of it is historical, related to funding, but also we have the opportunity to try and change that because we value the importance of trust-appointed doctors in the delivery of care of patients undergoing cardiothoracic surgery. Ram and Zaid will be talking a little bit more about that, and Shri later in the program. And also we are going to try and increase the training and operative opportunities for trust-appointed doctors. And again, Simon will be talking to you about that, how some of the schemes that we're going to be introducing. So why you're all here today is the launch of our sort of mentorship program, both for women in cardiothoracic surgery, but also trust-appointed doctors in cardiothoracic surgery. And this program is to allow either women or the trust-appointed doctors to develop a mentoring relationship with a consultant cardiothoracic surgeon, often ones that will have gone through a similar path than yourself, but not always, and will be able to give career guidance in this. And specifically, this is separate to the support provided by the clinical and education supervisors in your base hospitals. And this is to give advice and support in a number of areas, including professional development, maximizing training opportunities, subspecialty training, research and academic collaborations, and leadership development. The networking opportunities we've talked about already, and then achieving a work-life balance. And this is whether just in a full-time job, working less than full-time, working during pregnancy, returning to work following maternity leave, and also some specifics about becoming a consultant through the Article 14 and CSER route, which are particularly important for some trust-appointed doctors. The programme has involved matching that is done by the Women in Cardiothoracic Surgery and Trust-Appointed Doctors Mentorship Programme team, and you will have already been sent emails by them about who the different pairings are. The mentor and mentees are not necessarily from the same region because a lot of it can be done virtually or through modern technology. But it's important the pairing is mutually agreeable to both the mentee and mentors. And if there are any of you having any issues or would like to consider changing, please contact us. We'd encourage you though to give it a go initially, but if there are any issues, please contact us about potential changes. The logistics of the will allow us to determine whether the program is a success, whether the program is useful, whether it's something we should continue moving forward. So it's important for us to understand that. We'd expect mentors and mentees to meet for an hour, maybe every 1 or 2 months, depending on the requirements. And this cannot obviously be done by video conferencing platforms, and therefore should not be too onerous in terms of travel and other times. And if the parties were agreeable, this can continue beyond the initial 12 months program. And also, as I mentioned, we'll be having some networking sessions, which we can get the mentees and mentors to attend and get together and learn from each other. And then back to the rest of the equality diversity strategy that we're developing, we're also going to get commission articles for the bulletin and the website. And this is particularly important for those of you on the mentorship program, because you will be in a great place to give encouragement and support for those who aren't on the mentorship program and the others who are encountering some of these issues and how to overcome them. We're also trying to encourage appropriate representation from a diverse background for positions of responsibility in the society. And we're also trying to ensure that SCTS policy and documentation reflects the society's position on EDI, and that specifically include that's attributable to unconscious bias. So we're not perfect yet, but we are on a journey to try and make this happen. I wanted to stress what we're trying to do with equality, diversity, and inclusion is not positive discrimination. It's about positive action and providing equality of opportunities for all. So a lot of you on this course will say that there are some issues and that you've had to overcome related to different backgrounds. And that is what we are trying to do. We're trying to increase the opportunities for everyone to progress. This isn't about positive discrimination. The Kennedy report was actually very powerful in what it was, the ideas it was trying to promote, but it actually highlighted the SCTS about some of the examples, initiatives that we've already undertaken and used us as a positive example. So although we have made some progress, we realize there is still much more work to be done. And so I'd like to thank a lot of people for helping us develop this while I'm standing here talking about the Society's Equality, Diversity, Inclusion strategy. This has been, lots of people have contributed to this, not only the executive and the leadership of Simon himself, the Equality and Diversity Inclusion Working Group, the Women in Cardiothoracic Surgery Working Group, the Trust-appointed Doctors Education Team, the Student Education Team. But most importantly, actually, it's all the SCTS members who have a part to play in delivering this equality, diversity agenda. I'll leave you with a quote. Some of you may have seen this before. Change will not occur until those who are unaffected are as outraged as those who are. And it is incumbent on all of us to try and make things better, male, female, different race, to try and make the environment that we all work in a better place. And this is something I'm obviously very passionate about, but I think it is really important for all of us to try and take this forward. And thank you for all of you supporting this, and I value the opportunity to take any questions. Mahmood, thank you.
Thank you very much, Naren. And you've only cut out twice, which is a record for you with your bad Wi-Fi network connection. Any questions or comments to Naren? I don't see any in the chat, but if anybody wants to unmute themselves and ask a question, please feel free. I know it's the first talk and people are just warming up, but please do ask any questions. And even later on, if the question comes up in your mind later on, please do ask it. So thank you very much, Naren, for that review of the SCTS position on equality and diversity and mentorship. And I do think that our society is taking a very leading role across the surgical specialties, and we are doing very well in comparison to other specialties. So thank you, Naren. And we will also have Simon Kendall, who is the president of SCTS, later on as well, talking to us about the society's support for the different groups. I'll move on to my talk then, if we have no questions, or does anybody want to ask any questions? Your last chance. Unmute yourself, ask a question, and feel free. Okay. I'll move on to the second talk. And I will share my slides and see what happens. Good. Wish me luck. Can you see that?
Yep, that's perfect, Mahmoud.
It's full screen, yeah? Okay. Excellent. So I'm a consultant cardiothoracic surgeon here in Hull, and I've been leading on this mentorship concept since I was in the executive committee. I'm not anymore, but I'm grateful for the society for supporting me to continue with this. Why do we need mentorship? I'm going to try and make a case for it, and the case relates to differential attainment. What is differential attainment? It is the term used to describe variations in the level of educational achievements or attainments by between different groups, demographic groups, when they're doing the same assessment. This is a challenge in the medical arena and for all medical professionals and educators, but it's not limited to medicine. It's across the whole society and all fields and disciplines. And it is not just related to exams and assessments, it is related to all achievements within our professional life. But I will just mention a few examples of differential attainment. One is this, the second last exam, FRCS exam, that was held in Glasgow in December of last year. 30 candidates presented, 22 passed, 8 failed. The overall pass rate was 73%. If you try to break it down, you will see the huge difference here in attainment, with the trainees pass rate of 89% compared to the non-trainees pass rate of 50%. These are both groups of trainees or junior doctors that have been signed off as fit to sit the exam and suitable to sit the exam. But there's a huge discrepancy here. And even when trainees are on a training program and they're going for their ARCPs, there are differences observed between trainees who are UK graduates in red and international medical graduates. So international medical graduates do not seem to progress as much as UK graduates. They don't usually provide complete evidence. They are more likely, the international graduates, medical graduates, are more likely to require targeted training, and they are more likely to have their training extended, and also they're more likely to be released from the training programs. Another area where there is clear differential attainment, and this was identified in this document from 2015, the State of Medical Education and Practice, and it is a very interesting document to read because it does highlight a number of issues. This highlighted that international medical graduates, and this is not unique to the UK, it happens in the US and in Australia, are more likely to be investigated for fitness to practice concerns, as well as UK graduates who are Black or minority ethnic groups. And another factor to consider here in the mix is that although we can see in the proportion of female doctors across the UK varies between 41% to 50% in Scotland, if we look at, for example, Yorkshire and the Humber in cardiothoracic surgery specifically, you can see that in cardiac surgery, they represent only 17.4% of the workforce, although the female doctors are 46% of all the doctors in Yorkshire and Humber. Thoracic surgery does a bit better, but it's still only 1/4, and it's half of what it should be if we consider the number of female doctors across the Yorkshire and the Humber. And that's just an example, and I'm sure it's replicated in other areas. The other factor to consider here for our specialty as a whole is that we know that the number of women going to medical school or graduating from medical school is higher than men, and this is increasing. And although this shows the figures up to 2016, this is a continuing trend. So for our specialty, especially in the more unserved subspecialties in our cardiothoracic field, if we continue to have less women going into the specialty, this will create problems for manpower going forward in the future. And another factor also to consider here is that you can see from this graph that there is massive increase in the number of licensed doctors in the country from non-UK medical graduates. It's nearly, the number here in 2020 equals all the others, the UK graduates, the European graduates, as such. So it's about 10,000 doctors. So there is more women being in doctors. There's more doctors in the UK from BME group who are not UK graduates. And these are the people that we need to attract into our specialty. But how can we do that when there is this differential attainment present in what happens? But why does it happen? There's been a lot of research looking at why are the barriers for differential attainment. One is the wider educational sociocultural landscape, the macro environment, and this is affected by policies that we put forward and maybe the way we structure exams. But also there is the institutional culture and resources, the meso environment, and this involves the way we recruit people, the way we induct people into the specialty or into medicine in general, and what support do we provide for them as we go forward. And then also you have to consider the people involved. And yes, the personal attributes of the doctor do play a factor in their learning styles, in their cultural backgrounds, in their language abilities. But unconscious bias, which Naren has referred to, does come into play here in how we select people into the specialty, how we support them during their stay in the specialty, and how we achieve their success. And unconscious bias has many, many forms. I'll just mention some of them. For example, conformity, which is changing our negative assessment of knowledge or skills of somebody, depending on what are the others saying, rather than depending on what we feel if this trainee or this doctor is competent or not. Confirmation bias is only to look at what we want to see and look for evidence for that rather than what is really there. Contrast bias is when we compare a group that has just started with a group that has just finished. For example, F1s or F2s, comparing the ones that are starting in August with the ones that have just finished. It's not fair because the group that just finished had a year's experience behind them. There are many other forms of unconscious bias, which this is not the purpose of this talk, but we need to be aware of these and try and resolve them. And provide a culture of support for our juniors, our doctors, women in surgery, or trust-appointed doctors to work and function basically where we give them high level of support and at the same time challenge them to a high level. But if we just challenge them without providing the support, then that will lead to stress. And if we don't challenge them, but we give them loads of support, this will put them in a cozy club where they don't have to work hard or progress. So we need to balance the challenge of the specialty with the amount of support that we do give. And understand that the behaviors of our doctors is related to many, many factors, which we do need to consider in their background to help them support. And this is what mentoring will have to do, and to basically improve their resilience to succeed in our specialty and to enter our specialty and feel that it is a supportive specialty for them. So to counteract all these problems, we have introduced the concept of mentoring. It is identified as to have a positive impact on attainment levels. What is mentoring? It is the activity of giving a younger or less experienced person help and advice over a period of time. It is not surgical training. It is not educational training. It is not standing opposite you in theater teaching you surgical skills. That is not mentoring. The GMC, the BMA, the College of Surgeons all advocate the provision of mentorship schemes in all organizations, and this is why our society has taken this on board. This document from the GMC confirms that we all should be taking part in mentoring schemes offered by any employer, and that as senior doctors, and I know some of you are mentors here, senior doctors, you should be willing to take on a mentoring role for more junior doctors and other healthcare professionals as well. And once you agree to that role, you should do your best to fulfill that role by undertaking appropriate training. And this is what this course is about. It is providing some training and insights into mentorship, and then to keep up your skills. You do need to have the time and the inclination to do it and make yourself available for your mentee. The College of Surgeons has a document on mentoring, and it does identify mentoring as a highly regarded, empathetic person, the mentor, guides another individual, the mentee, in the development and re-examination of their own ideas, learning, and personal development. It is not, and it does clearly say this is not clinical or educational supervision. It's not counseling, patronage, or giving advice. It is not apprenticeship or surgical training. It is a relationship to allow people to progress and achieve their potential. And the key principles of mentoring, it should be entered into freely, both by the mentor and the mentee. There should be no coercion in it. You cannot force somebody to become a mentee or a mentor to do the mentoring. It has to be freely entered into. And any conversations they have, it should be totally in confidence, obviously, except if it affects patient safety. And there has to be an agreement from the start about the boundaries of the relationship. They should be identified, and the goals that they want to work towards should be identified, and then the mentor supports the mentee in achieving these goals and targets. The time element is important. Nareen has mentioned at least once a month meeting. I think that's reasonable for an hour to keep in touch. It might need to be more than that. It might need to be less than that, but that's a decision to be made between the mentor and the mentee. And the mentee is the one entitled to set the agenda. As a mentor, I don't come into a meeting and saying, we have to discuss this, that, and the other. It's the mentee's issues that we need to be discussing and finding solutions and providing support for. So the mentee should be providing the agenda for the mentoring meeting. But as a mentor, why am I going through all this effort? Why do I want to do that? It does give us the opportunity to reflect on our own attitudes and behaviors and consider this in relation to other people's experiences and behaviors. It does allow you to develop your communication skills, your team working skills, and leadership skills, which require active listening, attentive thinking, seeking clarification, and checking mutual understanding. And it's also, it has an altruistic motive, which is that you are helping your junior colleagues, and you might have not received the help yourself when you were going through this, but to help more junior colleagues in the specialty, it would be very rewarding and beneficial to our specialty in general. So thank you for listening to me. I will stop sharing, and if there are any questions, I'll be very happy to take them. So, excellent. Any questions, guys? Come on, you need to start questions. Otherwise, I'll start asking you questions. That'll be problems then. So there's a comment here from Kareem. Thank you so much. Very inspiring, progressive, and forward-thinking. I guess that goes to Naren, not me. So you get that compliment, Naren. So any questions or comments, guys? Feel free to either put them in the chat or unmute yourself and talk to us, and we will be happy to take them on. No questions? No, you too. No, I'm included in that compliment. And then it's not all to you. That's good.
It's all about teamwork.
Yes, it's all about teamwork. Right. No other questions. That's fine. Hopefully they'll come up as we go along during the course of the day. So,
Mahmoud, can I just make a quick comment then? Just on behalf of the Society, to personally thank you and Sham for starting the mentorship program and to bring it to the attention of the executive and making it happen. So just to say a big thank you for what you've both done with this.
Thank you very much. Thanks for that. It's very kind of you. It is an issue that I thought was very important and we were lacking in our society. And as I said, the GMC, the college, everybody says that we should have a mentorship scheme. So it was very good. And I'm delighted that you and the president took it on very passionately and have been very, very strong supporters of this. And it has spread to all the different groups involved in our society, which is fantastic. So our next talk is going to be from the Nhs Resolution Service. It is something that we hope you will never have to deal with. Sorry, Marian, but just it gives you an idea of the kind of support available there with regarding practitioner performance advice. So, Marian, I'll, if you wouldn't mind sharing your slides and giving us your talk, please. Thank you.
Okay, I'm going to try and share my slides. I'm hoping this is going to work. Let's just keep it as basic, actually. Okay.
Yeah, just while you're doing just before you do that, if you remind me, Naren, there's a question there about I think I can't read the question now, it's gone, but to rephrase it is, how can you measure the impact of these measures that we're introducing across trusts or across the specialty for that matter? Do you have any measurable tools?
So a lot of them, as with a lot of things we look at, are influenced by many different levels, and whether that's, as I said, things going on in society, things going on individual trusts and medical schools, and then also at the society level. As part of what we're first in terms of mentoring, that is one of the reasons why we've tried to set the goals so that we can then see whether the mentorship program has helped achieve some of those goals. The goals need to be achievable, but specifics to individuals. In terms of diversity and inclusion, the survey will give us the baseline demographics, and it'll give us baseline demographics into people's backgrounds. So we can see, for example, whether the percentage of women, as you put in your slide, have increased over the years that we've introduced the scheme. But it will also look at some of the issues that exist and whether we have addressed some of them. We've got to understand that we have a leadership role as a society in trying to change this, but a lot of the things have to be delivered at a trust level. And what we're trying to do is set a standard and a template on how things can be done. For example, supporting women when they come back, or women during pregnancy or when they come back from maternity leave. There should be an infrastructure that each trust has to support individuals. So as a society, we can help influence those things, but it still has to be delivered at a local trust level. And we can, by the survey and of understanding demographics and issues, we can hopefully demonstrate change.
Thank you very much. Sorry, Marianne, please go ahead. Thank you.
It's okay, don't worry. Thank you very much for inviting me to come along today. I think I came here last year, so it's really nice to be able to come back. I hope you can hear me and you haven't got too much noise at the background. So what I want to try and talk to you about, and I'm going to try and keep within time, but it is going to be a bit of a whistle-stop tour, is the work we do at Nhs Resolution. And I'm really principally just going to look at the work for practitioner performance advice. I'm going to try and pick up some of the things that have been discussed as well, just to try and put those into context if I can for you. And then if I get a chance, what I'd like to do is try and talk about the nature and origins of performance concerns and sort of framework. And if I get a chance, I'm going to try and almost make you answer some questions. So let's see if that works. So that's us in context. That's Nhs Resolution. So what I'm principally going to talk about is practitioner performance advice in the top right-hand corner. But we also are part of claims management. And in fact, that is effectively your indemnity policies. Safety and learning support claims management for trusts, and primary care appeals largely deal with appeals in relation to GPs. So that's not really going to concern you. So how do we support managing concerns and resolving concerns? Well, four main ways: advice, assessment and intervention, education, and healthcare professional alert notices. And I'm going to try and deal with each of those in turn. So case management services, I'm not going to comment on. I'm going to talk about advice. So who do we advise? NHS bodies, and in fact locum agencies as well, but also, just bear this in mind, individual practitioners as well. We provide advice to individual practitioners. The advice is free. I'm an employment lawyer by background, and I have to say, when I hear the word free, it always lights up for me, because it's always much easier to sell a service that actually is free. Apparently I have a problem with my internet connection. Is that correct? Can you actually hear me? Is there a problem?
No, you can carry on.
You can, okay.
You're cutting out on one or two words, but overall it's fine. Carry on, please.
Okay, all right, I'll try and carry on. So please keep telling me if there is a problem. There's no threshold for actually contacting us, and we receive about 1,000 requests a year. So really, we have probably seen any problem that you might have. The team itself consists of the advisor team of senior HR individuals, lawyers, clinical negligence lawyers. I'm an employment lawyer by background, medical directors, dentists, so a real range of within the team. We also work effectively with particular regions. So we have link advisors who work with those regions, not necessarily, although quite interesting, and it's just occurred to me as I've been listening to this talk, necessarily with particular types of societies, which is quite interesting, although we do a little bit of that in the background. So when to contact us? Well, I always say really contact us if there is something you want to discuss and you want a bit of a sounding board, because effectively that's actually quite helpful in many circumstances. So if you recall, the other thing we provide is various different types of interventions. And I'm going to go through each of those in turn in a moment with you, so you can see all the different interventions that we provide. Let's first of all look at assessments. So we provide clinical performance assessments, and those assessments, which we haven't been doing during COVID, as you won't be that surprised to learn, although we are now looking at doing them largely, some of them virtually. But that assessment involves a clinical record review. It involves looking at patient and colleague feedback, but principally it involves effectively a case-based assessment by an assessor in the same specialty. So for you, it would be obviously somebody in cardiology who would be effectively assessing your practice if you were in that situation. We also do, and a report is then provided from that. We also do behavioural assessments as well, which is effectively looking at behaviour, and we have been doing those throughout COVID, and we've been doing them remotely. Now, you might sort of say, oh, I don't think I'll ever need this, but actually in many ways, these kind of assessments are actually supportive as well, because they can support practitioners sometimes who have run into difficulties. And I always say to most doctors, and in fact most professions, at some stage you may well run into difficulties, and that doesn't mean there's anything wrong with your practice, but sometimes having that additional support is really helpful. We also do, and having listened to some of the talks earlier, professional support and remediation plans. And those might be action plans to help reskill, retrain somebody, or in fact, remediate them. But we also do return to work action plans. So for example, really helpful for somebody returning from maternity leave. A proper return to work plan is really, really helpful. We also offer team reviews where there is issues within the team, and we can look at working with the team and thinking about what steps can be taken, and we can advise on in terms of how to manage the team and what steps could be put in, or what steps could be put in place after a review of the team. We provide assisted mediation, which is a little bit more than just mediation in its own right, but it is delivered by accredited mediators, and it is looking at ways of working through relationship problems that exist quite often sometimes within teams. And the idea is to try and help those individuals to actually work together going forwards. Education, we provide a program of education for practitioners, and we do this through trust, but we also do public programs, so any doctor can sign on to a program, which clearly you'll appreciate we haven't really been running in the same way during COVID, but we are now doing those virtually as well. We all live in a virtual world now, don't we? I have to say, if you are case managing or involved in case investigating concerns, I think it's really helpful to have actually done that case manager or case investigation training, not least because it takes you through the entire process, and it's an interactive course over a couple of days. Just to let you know, we also, the advice service has taken over from the Strategic Health Authority, managing healthcare professional alert notices, which are where there are significant concerns about a practitioner and who might be a significant risk to staff, patients, or members of the public. And there is a concern that that practitioner, it's usually somebody who's leaving, might go to a locum agency, but there is a concern that that particular practitioner is then going to go and get another job somewhere else, and that you as an organisation think other NHS organisations ought to be alerted about that particular individual. It does not just cover doctors or dentists or pharmacists, it covers all healthcare professionals. So what I want to look at as well is thinking about how we manage concerns, or how you might manage concerns. So give you a bit of a flavour of what we do. I'm trying to keep an eye on time, so please stop me if I go over. So let's think about what is a concern. And I've sort of set out what the definition of a concern is that where you might see not just one-off in issues, but repeated patterns of mistakes, where there is a potential impact on the services being provided, possibly the efficiency of the services, maybe even the reputation of the services, and significantly where there is a risk to patients, there's a threat to patient safety, or there is a practice that is outside the normal types of guidelines and standards that you would expect. So let me give you some sort of background to all of that. So in terms of the number of doctors, and this information has come from the GMC, and you'll see it's pretty much up to date. So that's the number of registered doctors, that's the number of complaints received, and that might be complaints received from the GMC through various different sources, including the public, and that's the number of doctors who are erased or suspended. So it's pretty small. And then I want you just to look at the sort of concerns reported to us. If you recall, I said we get about 1,000 requests a year, and we've been in existence for about 20 years, as I understand it. So look at how the concerns over the last 5 years. The majority you can see are behavioural concerns, but also have a look at that overlap with clinical and behavioural, but also with health as well. That's the concerns looking at grades. And you, again, same 5-year period, number of cases, but look at the number. I'm hoping you can actually see the number of concerns in the box. But most of the concerns relate to consultants, which probably isn't that surprising because there are obviously more consultants, but they're also more, excuse me, in other grades as well than for trainees. And that isn't probably that surprising because, of course, with trainees, you'd expect a lot of concerns would be addressed through the deanery as training issues. So what I wanted just to have a quick look at as well, particularly bearing in mind who I'm talking to, is concerns by gender. And I think what's quite interesting here, you'll see, of course, less concerns. Well, I can tell you there are definitely less concerns about women than men. But actually, health is a much bigger factor for women. Sorry, I'll just go back if I may. And that's just some details, a slide showing gender in terms of assessments as well, and age. So you can see it's older males, really, to a degree, that undergo assessments with us. Now, this is a very old slide, but I've put it up here just to sort of try and make you feel a little bit better, although those figures have slightly changed, I'm afraid. You can see that obs and gynae is one of the big areas where we get advice is sought, and psychiatry and GPs as well. But there has been some more recent research through the Royal College of Surgeons, and actually the cases that we've had referred in the last, looking at 2015, 2016, and in fact 2019, 2020, about a quarter of the cases referred to us were relating to surgeons. So figures have slightly changed. Ooh, I just want to go back for a minute. So I said I'd kind of see if we could try and do a little bit of interaction. And what I want you to do is I want you to think about where you think concerns might arise. And if I can get this back, I wanted to see if you could just throw some thoughts at me in the chat box. And I'm looking at the chat box now just to see what thoughts you've got. Where might concerns come from? Any thoughts? Where are things going to be raised? I'm hoping I'm going to be able to see this. No, I've got a new message. Let me see if I can actually see this.
Can you see it, Marianne?
Yep, staff, absolutely. I can indeed. Yep, absolutely, I can. Staff, so colleagues, excellent. Surgical mortality, absolutely. Trying to just follow this through, sorry. Anything else? Has anybody else got thoughts? It's not covering all of them. Higher risk. Yeah, how to handle BME patients during pregnancies about women higher risk in pregnancy. Yeah. Okay. Yeah, so concerns, I guess, patients, I think, is what Faith is saying there. I don't know if Faith, if you want to, on clinical audit, gender bias. Yeah, so yeah, I'm kind of looking generally about where concerns might come from, but patients is certainly one of them. I think colleagues is one, and maybe you might say actually incorrectly. So that can also be the case. I think that's what Faith is saying. Trainees performance. I don't know whether everybody's sort of thinking trainees in terms of the trust, yes, staff, trainees in terms of trainees not picking things up. Okay, so Faith has said yes, I think that's what she's trying to say. Any other thoughts before I sort of show you where concerns largely arise? Anything else? Nope. Okay, let me see if I can get rid of this. Okay, okay. Okay, so hope you can see those. So I think you've covered a lot of those. Whistleblowing, and maybe that's what to some degree Faith was thinking about. Patience, obviously, feedback, safeguarding. So there's clearly something there about safeguarding. Practitioners themselves as well, and complaints. So we've got patient complaints, data monitoring. So occupational health as well. Remember I talked a little bit about health and that might be a factor. So occupational health themselves might sort of feed back in with complaints as well, with concerns. So I am not going to talk to you about MHPS because I think I could probably do a whole subject in its own right. Now, what I do want you to just be aware of is that maintaining high professional standards in the modern NHS, MHPS, is actually the process that would be followed if a concern arose with regard to a doctor. I always think that the BMA did a fabulous job in negotiating this document, even though it's completely not illegible, but it isn't very well drafted. But it does build in an awful lot of protections for doctors within that process, and that process has to be followed. So that is the process that applies. And you need to be aware of that if you find yourselves in a position of having to investigate concerns or manage concerns. So just some sort of common principles that you'd expect to see in terms of managing concerns. And so obviously patients need to be protected, but you need to bear in mind that managing concerns is very stressful for the person who is being investigated. And it is really important to put in place some sort of support. I don't need to tell you about some of the GMC, some of the reports you might have seen coming out of, people who took their own lives from actually being investigated by the GMC. So it's really key to make sure that support is in place. But it's also stressful for the people who are doing that investigation because it's quite difficult to actually investigate your peers. So support is very important. Clearly, the action needs to be proportionate. So if it is a one-off, you wouldn't necessarily expect any particular action to be taken. But it depends on whether it was a serious matter or not. But you need to be aware that if you can, you need to try and find a way of resolving that concern rather than making somebody go down a formal process which might not be necessary, and there might be another way of resolving it, possibly through some sort of action plan right at the outset. Information must be documented and retained. And let me just, since I'm here, talk a little bit about the process showing some sort of needs to demonstrate equality and fairness. And almost the starting point to some degree is just bearing in mind that a person who is being investigated must be made aware of what the allegations are and have the opportunity to respond. But I think there's been quite a lot of talk about that kind of question about whether or not BAME doctors are more likely to be investigated. And I think there's a need to ensure that you're aware of the quality legislation, that you take account of that legislation. And interestingly, I was talking last Friday, I was doing a talk last Friday to a trust who they sent me over their policy, and actually really interestingly, what they incorporate in their process, their local policies, is cultural ambassadors. And their cultural ambassadors are involved in the process all the way through. And in fact, they actually had one of their cultural ambassadors come and talk, and I joined the talk afterwards just to hear what she had to say, actually. And it was really interesting because their process involves an informal process all the way through to a preliminary fact find and then the formal process. And what was being very much encouraged was to actually get that cultural ambassador involved at a very, very early stage to see if there was actually some sort of issue that could be dealt with so much earlier on and during that process, to avoid unnecessary sort of investigations. So just taking account of time, I think just a couple of things just to be aware of. Tackling concerns early. And I also think about health right at the outset. Document, even if it is informal, make sure you have made some sort of note so that it can be passed on, so that if problems arise in the future, that there is some sort of record. And just to bear in mind that probity issues usually have possibly more serious consequences, not only for employment, but also with the regulator as well. So that's me. I'm happy to take any questions.
Fantastic. Thank you, Marion.
How to stop sharing. Can I stop sharing?
Yes, please.
Your screen's here. Can I stop? I'm going to stop sharing and see if there's any questions.
You have stopped sharing. Thank you.
I might have missed your comment 2 minutes. Good. I missed your cue for 2 minutes. Sorry.
No, you're right on cue. Well,
I don't know how many minutes ago that was.
It was 2 minutes ago. Perfect. No.
10 minutes ago.
No, it was 2 minutes ago.
Okay.
It was 2 minutes ago. As I said, thank you very much for it's the reason for this talk is to make mentors and mentees aware, first of all, the kind of problems that could happen, and also to show them an avenue of support. And that is very important to know. I mean, a lot of people might say, oh, I'll go to the BMA or the MBS or the Medical Protection Society, or so how do you differ from them? Or what is the advantage of coming to you rather than going to the BMA or going to the Medical Protection Society for support?
Do you mean as an individual practitioner?
Yeah. If
yes.
If a mentor or a mentee are dealing with a problem and the mentee has got into problems and the mentor wants to support them through your service, why is it better to go to you rather than to go to the BMA or to go to the protection societies?
Well, I think, okay, I think it is, I'm not suggesting you wouldn't go and get advice, But what we might be able to do, of course, is to help you work together, because think about some of those interventions I talked about. So think about sort of some sort of assisted mediation, some sort of advice to both of you in that situation. And it is, I wouldn't say adversarial is the wrong word, but when you go to your representative, your defence organisation or your professional association, they are very much there to support you. And it is probably less of an independent view. And I think sometimes that sort of extra sort of independence from us probably helps. Now, I'm not saying don't go to your representative, but sometimes when you're trying to unravel something, I think it's sometimes better to get that more independent sort of open advice.
Thank you.
Somebody has asked how we can access the training courses. Through, I think if you get to the end of my slides, there is details of our contact details. And if you go through effectively the main website, that's how you can do it. Or by all means, somebody can contact me and just drop me an email, and I can refer you on to our education team.
Excellent. Yeah. So Nhs Resolution, and then you can access some of the learning material. Any other questions, comments for Marion before she goes? That's fine. Thank you very much, Marion, for your talk and highlighting the support that you could provide for mentors and mentees if they run into any difficulties or problems during their professional relationship. So thanks very much again, Marion, and we will have you again for our future mentorship courses as well. So you did well in the first one. That's why we had you back. So you're doing well.
Thank you. And I do, excuse me, but I am going to have to go to another meeting. So if anybody's got any questions, by all means, Mahmood, you've got all my details, so please send them on to me.
Absolutely.
Thank you all.
Thank you very much. Thank you very much for your time. Thanks a lot. Thanks, Marion. Now for the next speaker I have, she will provide most of the meat for this course. So no pressure, Lucy. Yeah. You're going to provide
no pressure. It's fine.
No pressure, most of the meat for this course. Lucy is very kind to agree to talk to us again. She attended our first mentorship course last year, and she was a big hit. So that's why she's back with popular demand. And she's giving 2 talks this time, not just one. One after the break,
again,
and one after.
No pressure then again, yeah.
One before the break and one after the break. Lucy is our Head of Learning and Organizational Development here in Hull University Teaching Hospitals. She is very active in supporting mentorship, coaching, and the well-being of all members of staff, really, across the organization. And I'm grateful to have you talking to us today on explaining mentoring and how does it work. So it's over to you, Lucy. Thank you.
Thank you very much. So as Mahmood said, I'm Lucy Veer. Like I say, I've worked in the hospital trust and I've known Mahmood in various different roles over the years. But at the moment, I head up our education teams, and I also head up our organisational development team who kind of run our coaching network and our leadership programs. In terms of my professional background, it's occupational psychology. So I kind of bring that business psychology mind to what we do. I'm absolutely passionate about coaching and mentoring, and I'm just about to embark on my coaching masters. So I must be a fool, but I've got to put my money where my mouth is with this. So yeah, I'm really excited to be here today. And what I'm going to do is do mentors first, and then I'm going to talk about mentees, but it might kind of flow into one. So yeah, I just if you need to ask me anything, I'll try and keep an eye on the chat as we go. I have got some interactive stuff, so I thought I'll ease you in slowly, and I'm going to share my screen. I'm going to be using a product today called Mentimeter. Some people might have come across that before, but I'm going to ask you an easy question so that you can all get logged into your mobile phones first, and then afterwards we'll get onto the proper one. So I'm going to share my screen now before we get into the presentation proper. and then you can get all logged into Menti. And the first question that I have to ask you on a very hot, sunny day as it is here in Hull, I don't know if it's like that anywhere else, is what is your favourite frizzy drink? So what you need to do is go and log into www.menti.com, and then you need to use that code at the top to find out, and then it'll allow you to vote. I haven't got everyone's drinks on there. They were all the ones that I could think of. There's a range. So I'll see, and I'll be able to see the numbers coming in. Oh, lovely.
I'm still logging in. Let alone answer the question.
So I'm not going to rush you, Mahmood. You take your time. This is important data that we need today.
I hope the questions don't get any more difficult than this.
They just well, we'll see. You judge me on the end at the end of the presentation, Noreen. There's 8 people so far. None yuck. Yeah.
01.
Oh.
206.
See, I probably. Yeah. Here we go. There's about 28 people on the call. The numbers are coming up now. You can do it on your computer screen if you've got rubbish mobile phone signal. I won't leave it.
I just want to be clear. It is Pepsi full fat. Okay, not diet for me. Thank you.
I know there's so many different configurations these days, aren't there? Pepsi Max girl myself, Mahmood, I'm afraid.
Mahmood, this was meant to be anonymous, okay?
Okie dokie, right. I'm going to give you a minute to do that. And while this is counting down, I don't think we've really got a clear winner. If you'd like to say what other drinks you're having in the chat, I'd be really intrigued to see. Always looking out. If anyone puts margaritas, I'll just say not on the job. Otherwise, we might have to be having some issues around mentoring and going into different processes. So, right, there we go. So we've got. I don't think we've really got an outright winner other than other. So please share in the chat for that. Brilliant. I'm gonna shut that down now, but you feel free to keep putting that in. It'll still be on your screens, and I'm going to actually share my PowerPoint presentation. Just bear with me. Great stuff. Is that sharing okay for everybody?
Yeah.
Fabulous. That's great. So I'm going to sort of do the mentor's perspective, but I would ask the mentees to also listen, because if we're telling what the mentors to do, we can also, there's such a thing as managing upwards, as we like to call it in organisational development, and really. What I'm trying to sort of do today is give you some definitions. So Mahmood's already done some of that. But I'm going to give you this definition here of mentoring, very much in context of it being very developmental, which is the process and the kind of background that I come from. And you can see here, David Clutterbuck is big in coaching. He's a psychologist by background, and he very much talks about mentor defined as someone outside the area of authority of the mentee who has relevant experience in the field of work and is able to help with them. Of course, probably with yourselves, they may well be within your range of expertise, but it isn't necessarily needed. So I think as doctors and as surgeons, it can sometimes feel natural to go to doctors, but if there's a particular skill that you might need to develop, like leadership or working better with others, it's useful to think about a wider range of people who could possibly be your mentor and give you that support. And obviously you can hear that the mentor here is able to share their own experience in terms of helping the development of the mentee, but we'll also make sure that they're actually encouraging them to do listening to them through and actually questioning them, and actually really probably closer to coaching rather than some of the traditional definitions of mentoring. There's another one here which comes from the Chartered Institute of Personnel and Development, which is mentoring the workplace tends to describe a relationship in which a more experienced colleague uses his or her greater knowledge and understanding of the work or workplace to support the development of a more junior or inexperienced member of staff. And I think it's, again, really important to think about what does junior or inexperienced member of staff, and it shouldn't be based on the grade that you're on. It should be whether you have that skill or not. So I might be a very senior manager in the organisation, but there are some areas that I would potentially want mentoring on because it's not a familiar skill for me. So again, it's just making sure that you kind of use mentorship in the spirit in which it's intended, rather than worrying that it's not for you because maybe somebody's below your financial or grade, but actually they might have a skill that's higher than yours. That can be quite, I think the NHS can be quite hierarchical, so that can become quite difficult to overcome. So Mahmood, you've done some of my job for me earlier, so I'll give you your £5 later. Oh, has someone just come on the call? If you could just mute, that'd be fabulous. Thank you. That's brilliant. So in terms of mentorship, from both a mentee and a mentor point of view, it really helps to have somebody invested in your career. And I think this is quite difficult. We're having the conversation about this the other day in the trust about how does that fit into the inclusion agenda. But actually, I think some of the things that Narim said earlier, you need to have visibility. You need to be able to see people who are doing what you want to do, and to have somebody like that invested in your career can make a real difference and give you signposting and give you unwritten rules that you maybe don't understand. And so I think they're not mutually exclusive. Actually, I think they can work well together. I think the mentoring doesn't just go one way. From my perspective, when I've mentored, I've always benefited from that relationship. It's very easy to get smug in our own little worlds about what we think and what we assume. And often a mentee can maybe blow what we originally think sort of out of the water and give us a reality check sometimes. I think sometimes it's really helpful as part of being a mentor to have that. I think it helps both parties have that personal connection to the challenges faced. You might remember what it was like to be a junior doctor back in the day, but I would imagine it's very different from now. So actually, it's giving you a sense of reality and just checking in with your assumptions that you might have. And it connects to some of the biases that Mahmood was talking about earlier as well. And we tend to look for things that we want to see, and our brain doesn't like any dissonance. And mentorship can give you a little bit of that, but in a healthy way. For me, it really creates a fair and inclusive approach because it allows people to, again, to have that personal touch rather than just relying on the system to be fair. We can actually draw on people and individuals' compassion and leadership within it. And like I say, real world topics become personal than far removed via reports, papers, and also your own memories, as I've said before. I really want to talk about inclusion a lot in terms of mentorship, because something that we've been doing a lot of in the trust is really looking at how we become a more inclusive organisation, and it's actually going to become one of our core pillars of how we work at the trust. And I'm proud to have been kind of part of the team who are supporting the organisation to do that. And for me, one of the things I think, and I think this happens between professions, it happens between genders, it happens between different cultures. People fail to get along because they fear each other. My favourite example was when we used to do something called Pioneer Teams here at Huth, and we had a group of nurses who'd wanted to do nurse-led follow-ups for ages, but they didn't dare go to the consultants meeting because it was too scary. Okay, and so as part of this project, they decided to go to this meeting because we'd given them a deadline, and they got there and they'd built this meeting to be horrendous, and they were going to get, hauled across the coals. And then they got there and the consultants all went, "That sounds fabulous, when can it start?" And they'd not been for 10 years. And I think it's just kind of, it's not just, it's how do you have these boundaries and how do you get to know each other across those different boundaries. And communication for me is absolutely the key to be inclusive across all areas. And so I think mentorship for me is an opportunity to really value that diversity that you bring. I think seeing the data in the previous presentations has been fascinating to me, because we do tend to gravitate towards people like us, and that's fine. It's not that it's a bad thing, but how much we value diversity can really affect us, because if we don't value it, we won't look for it, and we won't understand what it will bring. And I want to read you something that I found yesterday, and it's sorry, it was off the Facebook, as my mother calls it, and it was a statement from rescueuk.org. And it says 8 of our 11 England players have at least one parent or grandparent born overseas. The squad shows us what we can achieve when we welcome diversity and celebrate those who call our country home. And I think that's just an ideal, example of why diversity is important and why mentoring can I think mentoring can support the opposite of go-to people. it stops people feeling excluded because they can have a personal relationship with somebody. People need to have connection in order to feel included and have a sense of purpose. What we don't want is obviously people to be excluded because of their position in the organisation. And I think a mentor relationship with a mentee, it can allow a more junior person to develop a human relationship. So actually the big bosses aren't scary anymore. They're just the person that you have a conversation with. And I think background, whether you've got a disability, regardless of your sexual orientation, your gender, what your ethnic background is, everyone has something to bring. It might come across in a slightly different way, and again, that mentorship allows you to do that in a much more personal way. It allows you to personally contribute rather than relying on the system to deliver that. I don't know about you, but I think as a mentor, you should definitely know if there are staff networks in your organisation, particularly if you have somebody who is having challenges based on one of their protected characteristics. We have an enabled staff network, we have an LGBTQ+ network, and we also have a BAME leadership network, and they're making a real difference in terms of having a voice, but also it's a safe place to be able to go and share experiences. So as a mentor, make sure you're connected into all of these different things. And I think at Huth, actually, myself and my colleague, we are looking at doing a women's group as well, because we think actually it'll be really helpful to think about some of the challenges that we experience based on gender across the board. This is an oldie but a goldie, but I also wanted to raise this today as part of that mentor relationship. I think people get quite mixed up about what equality is versus equity, and fairness often comes in. People feel that you have to do the same thing to everybody in order to be fair, and it's exactly the opposite of that. If you start doing the same thing for everybody, you could potentially be discriminating, and this picture is that kind of ideal example of that, where we've done the same, but there was one person who is absolutely excluded as a result of that. And I think sort of seeing the previous presentations, particularly about challenges with practice and NHS resolution, this could be a case where, if we are doing something the same for somebody, it could end up discriminating, and we could end up with somebody having difficulties. Obviously, one of the things that we're trying to do at the moment in the trust, I would say we're probably in the middle. So we're trying to be as fair as possible rather than equitable. We are trying to do positive action to allow people to have a different starting place so that they're actually able to get on a level pegging with everybody else. But I think what we're aiming for is to remove all of those things so that everybody just has the same opportunities, and the trust and our trust has a part to play in that. But I think as individuals, we have a part to play in that, and that's where for me mentoring comes in. So one of the things I wanted you to go away with before I go into sort of some of the theories and structures around coaching and things and how to do that. One of the words that we've been using a lot particularly is, how do you be an upstander and not just passively see something? So, you see, I'm not racist. And is it enough to be not racist? Is this a kind of concept of being anti-racist, and how do you do that? Or anti-prejudice, and being able to be an ally and finding out your place within that. So as a white woman, I will have some privilege, but there are other areas in my life where I have some challenges, therefore I might need an ally in those, but I can certainly use my position within the organisation to be an ally for others. And that requires me to treat it like a verb, to actively support and to use any power or privilege I have in service of other people. And that's what I try and do. I don't always get it right, but actually as mentors, you are going to have that opportunity to be an ally to people. You may well get told things that are difficult to hear. So how might you do that? How might you make sure that you're connected into the things in the trust, or up your skills that might allow you to signpost to people and support individuals? And so it's really about standing alongside people and making sure that you're there for them. So in terms of definitions, I just wanted to show you this, and I thought it was useful. It's the best one I've come across, actually, and it's from the Canadian Equality Forum, and I just really like the definitions here. Be a champion and an advocate for someone from an underrepresented community to support their career growth. And I think, this goes, allyship for me feels across for everybody, really. Be inclusive language, use, make sure that you're, working with somebody in the gender terms that they like. If they tell you how they like to be addressed, just do it. don't worry about, you know, the easiest thing to do if you're not sure is ask. Amplify the voices of others. So it's not about you speaking for that person. It's about you recognizing your privilege, as I've just talked, and amplifying the voices of others. So how can you create opportunities? How can you get messages heard in ways that they might not do if an individual is having to stand alone? I mean, the obvious one is call out bad behavior. I think we find this the hardest to do. And this is call out bad behavior both from patients and from colleagues. And there's a term, I don't know if you've heard of it, which is called microaggressions. And sometimes that can be quite a lonely place. And I've heard it described as kind of mosquito bites. So one's fine, isn't it, if you get one mozzie bite, but if you get lots and lots and lots on a continual basis, it's almost intolerable to deal with. And, you know, this kind of self-doubt. So really, how do you make sure that you call out behaviors? I remember an example where I was in a meeting, and we were assigning roles, and a male colleague assigned somebody in my team to making the tea. She was a woman, and I'm not sure that would have happened if she wasn't a woman. And you know, this is quite a while ago, but actually that is a microaggression. And it's an assumption that is what you'll do. Poor guy, actually, to be fair, in all future projects, that's actually the role that he got assigned. So there was a kind of we didn't really there was maybe on one occasion that happened, but it's just kind of challenging those stereotypes. Follow an array of voices and listen as well. There's loads of stuff out there. BBC Three on the iPlayer is fabulous. So if you don't understand what it's like to be a transgendered person, go and have a look. There's loads of stuff on there. If you don't understand, you know, Black history in the UK, get on there and have an understanding of that. It's just having different voices and hearing where that might have, and not assuming and working within your own biases, and actually seek training and beyond. You know, the best thing you can do is go out there and find some stuff. I'm constantly learning, and in fact our entire senior management team are in their first session today around how they're going to build a more inclusive organization. So they're actually taking responsibility for understanding how they need to do that. And then finally with this, it's being cautious of the pedestal effect as well. So you're not probably going to get a badge for being an ally, okay? So I just need to kind of give you that. It's not about your voice. It's not about kind of being that, I've heard the term white savior in terms of race. This is really about, you know, not over focusing on things, but actually just using the power that you've got in a positive way. So that's allyship. Does that make any sense? Has anyone got any questions before I go forward? But I just thought it was really important, particularly in this context, that I cover a little bit around inclusive behaviours that you would expect to see from a mentor, and give you some context. And it was brilliant to see the presentation earlier as well. No, I'm not seeing anything in chat. So, like I said, in mentoring, diversity is part of the discussion. You're going to learn about each other. You're going to learn about different approaches, cultures, different ethnicities, different communities. And really, I think it's an opportunity as well. If you're mentoring somebody, it gives you a voice as well to bring change to, you know, real change to an organisation that you're working in. And like I say, it's really a delight to see the work that that the society is doing with this as well. So privilege, mentoring and leveling the playing field, you're going to be at the front line of doing this. You're going to be really making sure that you're widening participation. I was noticing you kind of seeing everything from that work experience level, something I'm interested in from an education perspective, right through to the doctors in training who are going to be working with you. And it's about making sure you understand your privilege and see how that might affect how you might work with an individual as well. So you might think it's easy because it was easy for you and you don't have any issues. So it's just about popping another set of glasses on every now and then to make sure you're checking your privilege and supporting your mentee to kind of be at the playing field level that they need to be at in order to progress. So I've done the kind of finished the inclusion kind of bit. One of the things my mood knows is I'm passionate about coaching. So what I'm going to do now is I'm going to switch to Mentimeter, and I'm going to get you to reflect about where you spend most of your time as mentors. Okay, so I'm going to present you with a question, and what I would like you to do is rank it in order. So pretty much what do you do most of the time? And it's just going to kind of give us an indication of where you spend your time and how you tend to interact with people. So just bear with me while I stop sharing this screen. I've not perfected the professional face when doing this. I still have to look a bit. Just bear with me. Right. Can everyone see that okay? Yeah. So that should have come up on your mobile phones. So thinking about your own practice, where do you spend most of your time when you're working with people? Right, great to see some of those coming up. You can rank all of them if you want, or just do a few. It's totally up to you. Great stuff. Okay, I've had 8 people so far. Okay, brilliant. Keep going. Mahmood, did you want me to stick to the break time? Would that be helpful?
It's we did start late, and it would be nice to get back on schedule, but don't cut back on what you want to deliver.
Yeah,
as
no,
much as you can, but do try if you can. Thanks.
No worries. Oh, we're coming in thick and fast now. So we've got 14 people so far. I'm going to give you a countdown so that I don't run over time and you all do get to have a little break. For some of the more reflective preferences into a decision, I find a deadline's quite good for that. Set you a goal now, which we'll get onto in a minute. It's really positive to see. Really positive to see those answers. That's great. Any more for any more? Press submit. Go on. You know you want to. 20 last 20 seconds. Right, so we're coming to the end of that. So that's really positive to see that. I mean, it doesn't surprise me that you're spending a lot of your time in training. You know, that's either you'll be receiving it or you'll be giving it. I'm really just really bowled over by the fact that you're spending a lot of time listening to understand. That fills me with lots of confidence. Obviously, some towards the end, kind of listening, kind of asking questions that raise awareness, making suggestions, giving feedback. But again, it's really good to see that you're at that kind of reflective, listening to understand, and that gives me a lot of confidence. So I'm just going to go back to my presentation now. Just bear with me while I do that. Bear with me. Great stuff. Can everyone see that okay? Lovely. So great stuff. So the reason I asked you these questions is they come from what we would call the coaching spectrum. And for me, mentoring and having this in your head is really, really helpful. And it really talks about how directive and non-directive you would be, and kind of going back to some of the previous definitions that Mahmood gave and that I gave around what mentoring is. This coaching spectrum and having this in your head really allows you some freedom to kind of have some different choices when you're working with somebody. So as you would expect, the most directive thing that you can do if you actually press the screen properly is training. You're just basically telling what to do, and there's nothing wrong with that. I'm being directive today with you, and it's part and parcel of the spectrum. The next one will be giving advice. Now, people love to do this. Like, so someone asks you to give advice, it's like the best thing ever. And I'm going to come on to that a little bit later about why that can be helpful, but also can be unhelpful. It's fine to do it, but actually sometimes it can be unhelpful as well. Offering guidance is slightly less directive. It's similar, but not in the same vein, and making suggestions as well. So, you know, I'm not going to be obtuse if you ask me where the toilet is. I'm going to make the suggestion that you turn left and it's on the right. You know, I'm going to tell you where it is. I'm not going to go into coaching mentality with that. Giving feedback, again, it's going to be part and parcel, and I think that was quite high up on the scores that we had there. And then kind of as we get into the middle of the spectrum, you're getting less and less directive. I would say that asking questions that raise awareness is probably one of the most powerful but most unused tools, both in the NHS and across business. There's something that the most powerful question can stop you in your tracks and send you completely off in the direction that you needed to be but didn't know until somebody asked you that question. Clarifying understanding is great. Again, this is as a mentor, having that mindset where you're not having assumptions about what that person is saying or the conversation really helps if you're doing that. Just checking that what you've heard is actually what that person's saying. Paraphrasing is where you might take someone's words and you might turn them into a metaphor. The classic one, it sounds like you're between a rock and a hard place, and would be talking about a difficult situation for somebody. Summarizing exactly what it says on the tin, you would summarize what that person said, and that obviously then connects into clarifying understanding. Reflecting is where you would use what I would call clean language. So you would reflect back exactly the language they've said. So if they're telling you they're very upset and very frustrated, you would say that it sounds like you're very upset and frustrated with this situation. And it just allows the person in front of you to know that they have been heard and they've been, and also as a mentor and a coach, you're often a mirror. So when it gets said back to them, it can be very reassuring and it can create openings for them. Listening to understand is completely different to listening to work out what you're going to say next. Okay. Not very many people know the difference between that, but good listening is absolutely a skill. I have to work really hard on it because my brain goes about 12 bazillion miles an hour and I like to problem solve. So listening to understand is not you working out the problem and solving it for that person. It's just genuinely listening in order to do some of these skills here. And the most non-directive thing you can do is just sit there in silence and witness what that person's saying. And I don't know if you've ever had that happen to yourself where someone has just been present for you and has just listened and hasn't really interrupted you, has just let you speak and been there with you. And it can actually probably sometimes be some of the most powerful things that happen, because it just doesn't happen very often in our lives. Somebody's always got something to say. People immediately like to go down to directive because it's just easier to give advice. And if someone likes it, it's quite a nice little buzz as well. But really what I'm kind of getting you to reflect on is, how do you spend time doing things that you wouldn't normally do, and what on this spectrum might help you in your practice as a mentor, but also generally as mentees, you know, you might help you with people that you're interacting with as well. Does that make sense in terms of where we're getting at? Great stuff. So I would say here, training to giving feedback potentially might be seen as more traditional mentoring skills where you're in that expert mode. But really what I'm asking you to do is to say, do that. That's absolutely the right thing to be doing. Someone's coming to you because you are an expert. But also use these skills here as well in terms of further down, because they're absolutely available to you. And if you're not getting the result that you might want, what else could you possibly do? And some of these skills within that will help you with that. I had to put, do you know what, I did this last night and I feel like I jinxed it. I was terrified. I was sat in I was a knot of nerves, not just because of that. I thought, what if I've jinxed it? I put him up there because he's very different, isn't he, in terms of his descriptions that we're having. If you hear them talk about him, he is the definition not just of a football coach, but of a coach. I found it really fascinating the way that they've talked about his inclusivity and his team working and how he's valuing strengths and skills and what everyone brings. And I just thought I have to put him up here. And if you look closely at his waistcoat, it says it's coming home on it as well, which pleased me a lot on a very shallow level. And really, coaching is close to mentoring, but as you can see here from this definition, it's about the art of facilitating another person's learning, development, and performance. It's about raising self-awareness. And it's giving that person choices that they maybe didn't know they had, because by speaking it, sometimes people go, oh God, that's right. I processed it now. Thank you. You provided them a space to do that. Coaching is about allowing people to create their own solutions, develop their own skills, and change their own attitudes and behaviors. You're not telling them how to do it. And really what you're trying to do is close that gap between potential and performance. So thinking about some of that differential attainment stuff earlier, this is where coaching could really come into the fore as a skill to support people in that, because, I know that tennis players, you could have, exact physical kind of requirements, skills, but it's usually the mindset which is going to determine whether someone's going to be a champion or not. And that's really where the kind of art of coaching has come from as a practice. Another couple of coaching definitions. Coaches support an individual as part of a team or an organisation to improve business performance or operational effectiveness. And Miles Downey, bit of a legend in the coaching world, is the art of facilitating performance learning and development of another. So they're very closely related. And I think if you're mentoring without using coaching, I would be as bold to say you're maybe not doing it right. And I think based on what the society's definition of coaching is, I think that this fits in, of mentoring, really having that coaching approach and that mindset will help you a lot in your mentorships. So they do get confused. So traditional coaching that I would do as a kind of trained coach would be a one-to-one relationship, which is an individual is supported by someone who's experienced or trained in coaching practice, and we're supporting them to unlock their potential and achieve personal goals. And when I coach, I'm sometimes very directive, as in we use lots of structured techniques, and at other end I'm very much just listening and asking questions. Mentoring, like I say, is when someone's got a more experienced or a skill that they're bringing to the party, and they're willing to share it. But like I say, it doesn't stop you from using coaching skills within that. So I don't know if there's any Star Wars fans out there. I always have to get some sort of Star Wars reference. So I think that in the NHS, because of expertise and the need to pass stuff on across all kind of clinical professions, sometimes things did get a bit Darth Vader, do you know what I mean? And you will do this and, a bit dictatorial, this is the way we do things. And of course, I'm not suggesting that you should be wifty-wafty about clinical skills. I wouldn't want you doing that in the suture centre, Mahmood. I would be wanting you telling people how to do that. That's not what I'm saying. But actually how you facilitate that learning needs to be more Yoda, which is allowing people to understand what it is that's possible for them and assume that they have everything that they need to do the job, but they might just need different ways of opening up to that. But as Yoda says, there is no try, only do. So we do need to have that challenge within there as well. So I wanted to talk a little bit about the core skill set. And for me, contracting with somebody who is a mentor is really, really important. And I would really like mentees to listen up at this point as well. I am going to repeat myself later. It really is a two-party thing. So I think contracting can cut off, any issues that you might have later. It might be quite formal because it's an education mentorship, or it might be less formal because it's professional, but be really clear about what it is that you want from it. Coaching mindset and skill set, and I'm going to give you a couple of models on that in a little bit. Support and challenge that we've talked about, so about creating trust and psychological safety. Also checking understanding. Particularly if you're in a senior position and you're a mentor, you need to give them permission to ask you stupid questions because they might not want to, because they won't want to look stupid in front of you. So how do you create that safe space in order to do that? And mentors, I would like to caution you about giving people your full career. from the age of 14 when you got the Headmaster's Award. You know, you need to be able to offer your advice without taking over the agenda. Okay, it's not about you just relaying how you would have done things, but it is about what you bring to the party with your toolkit. So being a mentor with a coaching mindset, you're going to come with that knowledge and experience, which is useful for your mentee. But what I'm asking you to do is put away your assumptions about what the mentee wants and take the time to understand their goals and needs, because they may well be different from you. If you're from a different background, different gender, different family life arrangements, you might have different goals about what you need. And you're sharing your expertise in the service of the mentee's goals and aspirations, not just to show off. All right, you can do that a little bit. All right, I will give you a little bit of that, but it is really, you know, about in service of their goals. And how could you up your skills to really use coaching methods alongside more traditional training and advice? And it was really brilliant to see that actually a lot of you were doing that already. But it's actually, what does that look like, and what else could you do? So coaching skills and models. I'm going to go into a few of them in a moment, but goal setting is a real aspect of that. But I'm going to flip that. I'm going to talk about goal setting for mentees and what I think they should be able to do, because I think it's important for a mentor to have those skills, but almost it's as important for a mentee to understand how to goal set. Listening skills are vital. Having the ability to form high quality questions, and I'm going to show you how to do that in a minute. Getting into self-directed action, so you're not rescuing your mentee. Okay, so it's not your responsibility, it's your responsibility to be a good mentor, but you can't do it for them. I'm going to give you the T-Gro Model, which is a classic coaching, very simple way to have a conversation, and I'm going to talk about solution-focused thinking, and I'm going to leave you with some resources to take away with that so that you can use that. I am going to talk about self-directed learning, but I'm going to put that in the mentee section, because again, it's about how does that mentee take responsibility in this relationship as well. Mahmood, how am I doing for time?
I think we have another 5 to 10 minutes. Yeah.
Yep, great stuff. Thank you. So most people know SMART goals. Would it be fair to say? So specific, measurable, achievable, realistic, and time bound. I think they're some of the hardest things to do, SMART goals. They're really, really difficult. And I think people know how to do them, but they don't really. I've learned through some of the development I've done over the past few years that there's another 3 types of goals. One is called umbrella, which is I'm going to go through in a little bit. Qualitative goals and visioning. And what they do is they allow you as a mentor to filter when that mentee comes to you and understand how might I best help them set a really brilliant goal. If you try and go too smart, with the SMART goals, it blows people's minds because it's too specific. And often I don't even know what I want sometimes on a day-to-day basis. So actually having these other goal setting technique in your toolkit. Like I say, I'm going to cover how to do these specifically in the mentee section after the break, but I just wanted to put goal setting in mind, because it's a clear, if you don't have a goal, you're probably not mentoring and coaching, you're just talking, which is fine. But actually, how do you make sure that you have something that you're both aiming towards? So high quality questions. This was actually a bit of a revelation to me, because I used to struggle when I first coached, because I'd be always wanting to think of the most fabulous question and I'd forget to listen to the person in front of me. And this is a really, really simple way of having rules about how do I ask questions that raise awareness, and how do I do that really effectively. And there are 2 ways to do this. One is to open the mind. So you're trying to get people into thinking bigger and wider. So you're looking at those options and what could you possibly do. And you would always start a high quality question with a how, what, or who. And I'll come on to why in a minute, and I'll tell you why, but just park that for a moment. If you're wanting to ask questions to somebody who, to open their mind, you would add a possibly, could, or would. So the example here is, who could you possibly involve to help you? So if I was to say, I'm going to pick on you now, Mahmood, what are you having for tea tonight? What are you having for tea?
I don't know.
Yeah, there you go. I put you on the spot, so I'm going to ask it in a different way. Okay, what could you possibly have for tea tonight?
It would be some kind of meat, I hope.
Exactly. And so while it is a very basic question, by adding the possibly in, you're under less pressure, aren't you? Because I'm not asking you specifically what you're going to do. I'm giving you some options, and your eyes went up and you went to start using a different part of your brain at that point. But I won't push you any further. We can discuss it later. It's fine. And so when you say, what are you going to do? It puts people under pressure, and you might get answers that aren't very good. But adding a possibly or a could or a would in there, so it just really allows people's brains to work in a different way. So, you know, if you're faced with somebody and you're looking at a clinical problem and you're wanting them to be creative, you know, what else could you possibly do in this scenario? You know, and it's just adding that possibly takes the pressure off, and it just opens another level of creativity. So kind of bringing some of those areas into your, you can do it in email, you can do it in face-to-face. It's absolutely brilliant. But we don't just want to open people's minds, we do want to focus them as well. So there are questions to focus minds. So don't be afraid as a mentor to say, those ideas are very lovely, but by when are you going to do that? I think it's great that you want to go and get that work experience, but who do you need to contact in order to do that? So what you're doing is you're really closing them down and actually trying to get them to commit, because it's not your responsibility to phone up the person to arrange the meeting. You know, if you're going to make contact, you know, you want to make sure that you're able to close that down. So by using this kind of high quality question technique, it just gives you some options in terms of how you have those conversations. And you can, you know, if you listen to that person, you can use a high quality question to feedback some of the things that they've been saying to each other. So I love this template. I kind of almost have it in, you know, tattooed on the inside of my head when I'm working with people. I'm just going to pick up why and why we don't use why in a coaching situation. It's not that it's banned. If you're looking why someone has a purpose or a reason why, I think it's perfectly reasonable to explore that. But if I was to say, Mahmood, why are you having meat for tea tonight? Mahmood might be like, I don't know why I'm having tea. Oh, you know, it immediately would put you on the defensive. And I think that,
I mean, that's...
Oh, I think someone's just come off mute. Can I ask you just to pop yourself back on? Thank you. I think that why can be quite destructive in relationships, particularly if you're a trainee and someone went, why on earth did you do that? Imagine if someone just said to you, what happened? Or what else could you possibly do next time? So it also supports safety culture for me by stopping using why in those scenarios and moving into a high quality question, because what you will do as a mentor and also as a practitioner in clinical practice, you will start to build psychological safety with that. So if you can just check how many times you say why. I'm not sure you will do it with your children, but I think that's fine. But from that point of view, it's just really important that you just kind of have a think about the questions and just notice how you ask questions to people. So I'll do these coaching models, Mahmood, if that's all right, before the break, and then we'll have a break, and then that seems to work out well, and I can pick up the other stuff afterwards. So one of the most famous models is called the T-Gro model from a guy called Roger Whitmore. You can get his book on Amazon. I'll send the links. It's a good introduction to coaching. And if you've got any coaching courses in your trust, I do highly recommend that you engage with them. I also know that Health Education England often run training qualifications for doctors as well, in order for you to get your coaching qualifications. And again, tap into that because it will make a big difference. Basically what T-Gro is a model that allows you to structure a conversation. It isn't linear, so you don't have to go in any particular order, but I will go in order today just to kind of illustrate what it allows you to do. And the idea is if you're in a conversation with somebody, the first thing you would ask them is, what do you want to talk about? What's helpful to talk about today? Now, if I'm in a coaching relationship, we might have a bigger, wider goal, but if someone's had a really difficult day, they might want to talk about that today, rather than actually, you know, the wider career goal that they were originally engaged with me for coaching. So what do you want to talk about is a good place to start. The goal, what would you like from the discussion? Or maybe you're seeing someone on the fly and you've got 10 minutes. I've got 10 minutes. What will be a useful outcome by the end of this 10 minutes? So it's a really useful way to do that. So make sure in mentoring and coaching, you have a goal when you're having these conversations. One of the things that people will love to do is explore reality. So they will tell you about everything that's going on and about how awful it is. Okay, and you're allowed to do that. It's just not a final destination, because it is important to work with somebody and explore barriers, to understand what's happening in their world, in order for you to know how you might help them and how you might usefully help them. So actually allowing people to explore and describe what's happening now, and using high quality questions to tell us about that. Again, avoiding why in that scenario works really well. Options, that's when your high quality questions to open the mind would come in. So this is where somebody might have presented a goal, told you all the barriers that are in the way to get there, and that might be, I'm not feeling confident, I haven't got enough time, you know, between homework, kids, work, I'm just not getting stuff done. So it might be time management issues are happening. This is where you're then allowing them to explore what else they could possibly do, who else they could possibly involve, you know, what is it. I think sometimes when you get into options, you sometimes have to go back and revisit the goal, because it isn't realistic. So actually you might go round goal, reality, options, back to goal, back to options, back to reality, and spend a number of, you know, this is probably where you're going to spend most of your time bouncing between these three things in the conversation. This is what will you do? So this is the high quality questions you would be using in order to close the loop and to say, what are we going to do, and get them to focus their mind. And this is the bit where you have to resist as a mentor taking on the actions for them. If it's simple stuff like, I will contact a colleague if you would like to speak to them, absolutely fine. But what we don't want you doing here as a mentor is rescuing. This is about you wrapping up and really kind of getting the mentee to focus on what it is that they might want to do. It doesn't have to be grand things, but it could be one or two things that would be helpful. And a really great question to ask is, what is the one thing that might be helpful leaving this conversation for you to do? So you can keep things really, really simple. Like I say, this isn't linear, but it is just a really sensible way to structure a conversation. And when I'm in a conversation, I'll often have these headings in my mind. And have I spent too much time on one of them? Do I need to go back to it? And my advice when you're having conversations, time is never wasted on the goal. So make sure that you're really clear on what it is that you want to do and what that individual wants to do. And don't be afraid that if you spend a lot of time on that, because it will really set you up well for the rest of the conversation. The other model that I've used a lot, I have to say I've used this a lot in the pandemic. As part of my role in the pandemic, I was redeployed to look at staff psychosocial support. And me and a colleague did a lot of personal coaching, you know, rather than kind of career or performance-based coaching. And I used a lot of this because I found that while there were people who were very, very, you know, some people were very distressed, the stuff that myself and my colleague dealt with was kind of some of the low-level stuff. And this is a really useful model when someone's kind of window of tolerance has gone from being really big and life is good and they can cope with everything to being really small. This model can be really helpful for people to find maybe one or two little things that they can do. And it's based on some research that's been done on how do people make a difference. And so you can make a difference to yourself on an individual level, but this also works well for bigger kind of organizational and career and service goals as well. So you can see there's lots of similarities from what I've shown you with the GROW model, in terms of you would always define a goal. But what they have included here is what they would call the internal triangle, which is just doing this check-in. So it's kind of setting the goal with, you know, plus loads of other stuff. So if you remember the Spice Girls song, tell me what you want, what you really, really want. It's not zigga zigga, it is, but do you think that's achievable? So define the goal, so you tell me what you want. Do you have a strong reason why? So do you really want it? One of the things that's quite helpful, I find, is getting people to use scales. So on a scale of 1 to 10, how much do you want this? With 10 being, I want it more than anything in the world, and 1 being not really. So if someone's saying, this is a really great goal, but I'm at a 4, they don't really want to do it, do they? Do you know what I mean? They're paying lip service to it. So by doing this process with the goal, it allows you as a mentor to understand, is this what they really want, or are they just paying it lip service, or even trying to show you that that's what they think they should be doing. So it allows you to explore in a bit more detail. The other thing that often stops people is their self-belief in whether it's possible. And so actually, you can use a scale with this. So on a scale of 1 to 10, how achievable do you feel this is? So I know this is your goal. I know you really want it, but do you actually think it's achievable? So you might be at a 9 for reason why, but actually your self-belief is at a 4. And then as a mentor, you've got something to work with, you know, so how can we get your 4 to a 5 and a 5 to a 6? It's an arbitrary scale, but it allows you to have quite interesting conversations, and it often promotes really good thinking in that mentee. So that's what we would call the internal triangle, and that's very much around goal setting and getting that right. The other aspect of it is then once you've defined a goal, is that you would then move into possibility thinking. So the previous GROW model, that would be about options. And this is where you'd use lots of those high quality questions that would open the mind and get into possibility thinking. One of the other things that they talked about was involving others. So we often think that we all have to do it by ourselves, because by nature, often humans, we're quite competitive. So I put a plea out here. You don't have to do it all by yourself. You can involve others. The last two things that I'm going to mention on this one is about personal responsibility. And so this is about, how do you ask that individual, are you going to take personal responsibility for having a good goal, for having a strong motivation, for making things achievable and focusing on that, for creating ideas, involving others. And then finally, you're asking somebody, are you going to take action and measure results? So again, these are just conversation frameworks. They're just kind of markers for you to hit within that conversation, but it just allows you as a mentor to have some of those structures and just kind of tick some of these things off. And what I'm going to share with you, but I'll do it as kind of a piece of not homework, but as a resource for you, is a blind coaching script. And it basically has about 40 high quality questions on there that takes you in order through this model. So you could actually use it. And you can either do it without interacting with somebody. So I've done it where I've just read it out and the person writes it down, and that can be quite helpful. Or you can use it as a script if you're in a conversation with somebody to give you ideas about that next question that you might need to ask. So with that, I'm gonna have a pause there, and we'll have a little break if that's okay, Mahmood.
Perfect. Thank you very much, Lucy. Obviously, a lot of stuff there to digest, and over the next few minutes while we have a break. Just before we break, there's a question. I find it difficult to understand how being a silent witness is helpful. Am I relying on the person's introspection?
Yeah, so it's not saying that. There are some coaches who would say just sit in silence for an hour. I'm not one of those. That would kill me. But silence, people are very uncomfortable with it. So when you ask a question, you need to be quiet in order to allow that person to answer it. Now, my brain goes very fast, so I have had to teach myself that what I think is a long time isn't a long time, and I need to give longer. Silence introspection, you're absolutely right. You are relying on that person, and you are being quite purist in that you're expecting that they will find the answer themselves by talking it through and you just listening. So really, they're not silent, it's you being silent, and you're allowing them to talk and giving them time and space. Just check how comfortable you are with silence when you ask a question, because it's a skill. It's a big skill, and if necessary, sit on your hands and wait another 30 seconds, because it's never enough.
Thank you. Any questions? If you put them in the chat, or if you want to unmute yourself and ask a question. The other question that came up to my mind is when Naren was talking about equality and inclusion, he put the idea forward that it's not positive discrimination, but I thought you mentioned that you're in sort of in support of positive discrimination. Did I get you right? And where do you think is the right way to go?
No, I would say I'll be talking about positive action. What I'm requesting is that you treat people as individuals. So we've been talking about this. I don't share this very often, but I have a disability. I have a hearing impairment. And through the pandemic, I've had to out myself to so many people who I don't know because I wear a hearing aid. And I need some different, so for me, this is perfect because I can see you all, I've got headphones on, and this for me is a meeting at the moment. I've had to request this more often rather than face to face and being on thing. And that for me is an example where what you've done is if you put me in face masks for the most of my time at work, I would have been able to be really ineffective. And I'm sure there are people out there who are finding this very difficult, who haven't had the privilege that I have to be able to work in the way I want. So I'm not saying that we should positively discriminate. I'm asking that we treat people as individuals. And I think our trust did that quite well. I don't know how other trusts did around PPE by expecting you know, by accepting that enhanced PPE was right for some of our BAME colleagues, regardless of what everyone else was wearing in a clinical area, because of the risk factors that were being identified in the pandemic. And for me, I would call that positive action and not discrimination. That was us acting fairly, not acting wrong. So that's kind of what I meant, if that makes sense, Mahmood.
It does make sense, but it's just you could flip between the two sometimes without knowing.
Yeah, I know, I would agree with that. And I think it's really hard for leaders and managers to know what is the right thing to do, because if you're doing one thing for another person and the other people see why you're doing that, it can feel unfair to others, even though actually you're probably doing a really good job for that individual. We do a positive action program called Rising Up, and we've done that for our BAME colleagues. And for me, that was a really important thing to do, because actually things are different and the system is set up and there is systemic discrimination, and we have to put those boxes at different levels. At the moment, I wish it wasn't like that, but it's just the reality of it. And there's actually new data coming out around disparity ratios. I don't know if you knew that. I was going to mention that to Narain in terms of measures for some of this stuff. So NHS is really looking at what are the differences in terms of pay grades and all of that sort of stuff, and are going to be setting targets to trusts that they have to close those disparity ratios. So there'll be some really interesting measures, I think, and levers coming up for us to be able to do some of this work really well.
Excellent. Good. Thank you very much, Lucy. We're going to take a break now. It will be the full 10 minutes. So it's 20, let's say it's 20 past now. So we'll be back at half two to restart again. I know this is eating a lot of your time, Lucy, but I would appreciate if you could try and condense a little bit your talk, the next talk, so that we can try and get back on schedule.
No problem.
Thank you, everybody, for being with us. Back at half two, and have a quick break. Thank you. So I'll let you take over again. Thanks.
Yep, no, that's great. So it all flows in together. I will bring it all together at the end. So I'm just going to shift slightly now to the mentees perspective. I'm aware that I have gone at like whistle stop pace with this. There's so much I could do about a day on each of these subjects. One of the things I wanted to start with, I don't know if anyone's seen Cartman's drama triangle before. And as head of education, I actually sometimes see this in students, in staff. And I love this model, and we use it a lot, is because the drama triangle talks about the roles that we play. And my real request to mentees is that you don't ever end up in the victim status here on this triangle. And victim can be seen as a bad thing, but sometimes it's quite a good thing, because you don't have to take responsibility for yourself. So within this drama triangle, it's talking about how people interact. And you can see here at the bottom that often if you're in victim mode, as I will call it, or sometimes you've maybe got your victim t-shirt underneath your scrubs, it's about acting as if you don't have any power. It's about avoiding self-responsibility. You sometimes can appear helpless or act helpless. You will know you're in victim mode if you are saying it's not fair a lot to people and to yourself in terms of your self-talk. You might feel you're blamed, or you blame others for things that are happening in your world. And, you know, you might be feeling stuck, feeling of unsupported. And it's just really kind of, as well, it can sometimes create through our emotional states. If you're not feeling worthy, you're feeling kind of useless in things that you're doing. And it can be a really difficult place to be. But what I'm asking you to think about is sometimes that victim mode self-made, in terms of it's quite a comfortable place to be, because it means you're relying on others to make decisions. Which then brings me into the other two positions on the drama triangle. And mentors beware. Okay, this is what I don't want you to do is end up in the hero, martyr, or rescuer position. Because when someone comes to you in victim mode, our natural instincts as humans is to help, and that's absolutely okay. But if you say things like, leave it to me, I'll look after you, don't worry, I'll sort it out, you might have a way that you might like to do things. So this is if you're thinking about the coaching, I've lost the word now, sorry, the continuum, apologies. You might very much go into that giving advice mode, and kind of really telling people what to do rather than being less non-directive. And you can often react from guilt as well. I think it's very hard if you're feeling guilty about something, you might want to try and resolve it and problem solve. What often happens though is from either martyr or victim and rescuer, you can move into this bullying persecutor mode, where you're kind of going, well, if only they'd done what I told them to do, they wouldn't be in this position, because the victim doesn't really take your advice and they just do what they want to do anyway. You can be judgmental, you can get angry, you might punish others. But equally, if something that the rescuer told you to do, victims can also very quickly move into bullier persecutor. And it's kind of a cycle that goes round, but inevitably you always end up back at that one position. So Cartman's drama triangle is really a model that talks about a lack of self-responsibility, and that's you taking that away from other people, equally you kind of giving that over and trying not to take responsibility for yourself. So mentoring and being a mentee is the exact opposite of being on the drama triangle. And so the antidote for being a rescuer is being a coach. So instead of solving people's problems for them, you ask questions that raise awareness, you help people set goals. Instead of being a victim, you take responsibility for your own development, your own actions, and even if it's, your well-being, you're struggling with that, there's usually one thing you can do to support that. We're not asking you to change the world, but it's about what is the one thing that I could get in control of, and actually taking self-responsibility for that. And then instead of being, that kind of persecutor, what you do is you move into that challenging mode. So you're kind of in that by when, well, what would be helpful? And you're kind of allowing people to, you're not putting them in their panic zone. You're moving them into kind of a slight comfort zone. So maybe moving from an armchair to a wooden chair, rather than kind of throwing them off the cliff and saying you've got to do this. So this is the mindset that I would like a mentee to have, because it means that you're taking responsibility for yourself, and it means that you're going to get a better relationship from your mentor. And this is about empowerment of each other. One of the best ways that you can do this is to have a really good goal and to spend some time thinking about what it is that you really want. I've already talked about SMART, and I'm not going to spend too much time on it because most people know how to do it. And it is just really having very specific things that you might want. So you might have a very specific training goal that a mentor could help you with. Don't be shy, be clear about what that is, and spend some time thinking about that. Sometimes SMART goals are too specific and you don't know. And one of the things that you can do is to think about an umbrella goal. So obviously I've put you might want to be the best cardiothoracic surgeon in the world, and I hope you go for it. And really that's a big goal. So how are you going to do that? And really what an umbrella goal is, just you kind of sitting there either with a bit of paper, drawing this out. And, so I'm suggesting that you need the right mindset. You're also going to need good leadership skills in order to be a cardiothoracic surgeon. You're also going to have to work in the best hospital. You're also going to have some great training, and you're also going to have the best mentor. Okay. So really an umbrella goal is about, what is the things that I need to do, and ask yourself, so if I do all of these things, will I be the best cardiothoracic surgeon in the world? And it's just really a process that you can ask yourself. But mentors, this is also a really good technique when somebody comes in without a goal. Hello, can someone mute, please? That's perfect. Thank you very much. There we go. And what umbrella goals are quite good at doing as well is, so for instance, you might come as a mentee and you might have 3 or 4 of these things already in place, but you can use your mentor to maybe, for instance, prioritize and help you get the right mindset. So what might be the smaller goals that would come out of that, and eventually your SMART goals will fall out of it. So if you're a bit overwhelmed and you can't really think of a fantastic SMART goal, use this umbrella technique to kind of, really kind of help you get it is what you would like. If your needs from a mentor even are more qualitative, so you're not feeling confident, or you're not feeling you've got the personal impact, and how you might want to manage different relationships, because that is a reality working in a large hospitals, particularly large teaching trusts. You know, we are an eclectic bunch across the board, and sometimes relationships or confidence can be impacted by that. And it's about how you as an individual think about what you'd like to improve. And again, I would suggest that you use a rating. So you can do this as a self thing, or a mentor. You might want to do this with an individual. So you can think about, well, I'm not confident in this situation, but can I remember a time where I have been confident? And how might I translate that? Was it the same or was it similar? Have I got a role model that I might want to use, maybe fact or fictional? I think Wonder Woman's always a great role model to think about. And get people, you know, really describe what that looks like. Be specific about, like, what does feeling confident mean to you? Because a lot of people say, I want to communicate better, I want to be more confident, without actually spending the time to explore what that would mean. And if it means that you get to get your point across once in a meeting, that's a very specific qualitative goal. And if you come out of that, it means that you might want to do, I'm going to say 3 things next time in the meeting with confidence. It's all about you being an agent of yourself and defining what it is that you want that to be, rather than going into victim mode and go, oh, I wish I was more confident. This qualitative goal setting really gets you to get into those specifics. Vision, had to get Back to the Future in there. This is probably, I think, sometimes the thing that people find really hard, because we often get stopped by the reality that we're in at the moment. And really the visioning is about you almost stepping into the future and imagining what you want has happened already. And then really sort of imagining what that looks and feels like, and describing that, because then that helps you set the goal that you want. So if your vision is to be the best cardiothoracic surgeon in the world, imagine you're there already. What is happening? You know, what's around you? What does your office look like? You know, who are you speaking with? What sort of work are you doing? And that really helps you draw out all of those kind of umbrella goal bits that you might want to have. And as a mentor, this is a really, really good thing to do, but it's quite hard to get people from reality now and get them to kind of, you know, get in that time machine and imagine what that looks like forward. And you can do visioning with a long vision, so 10 years in the future, but you could even do it, you know, 2-3 weeks in the future, or, you know, end of the day, if that's what you really need to do. It's a really useful technique to spend some time on as a mentee, so that when you're going into a relationship, you're well prepared. But also at the same time, mentors, this is a really good technique for you to work with people as well. So I'm going to finish kind of rounding up what I think is great for a mentor by using Boyatzis theory of self-directed learning. This sometimes, when we can't remember the name, gets called Mike Wazowski's theory of self-directed learning from the Monsters Inc. thing, but that's normally when we can't remember it. So if we don't remember a theory, just call it Wazowski's theory and go with that. And I really, really like this, because it's something you could do almost as a standalone thing as an individual mentee. But mentors, again, if you've got somebody coming to you and they're a little bit on the drama triangle, okay, you can use this to support them in a support and challenge way, to allow them to come off that drama triangle. And mentees, you might find by going through this yourself, it brings you off it naturally, so you can get into that kind of more kind of functional, focused and creative mode of thinking. And as you can see here, it's really getting you to do some of that visioning stuff there. It's also getting you to check what is the reality. So you can see some real similarities here between the GROW model and that solution focused thinking. What I really like about this is it gets you to look at your strengths, because I think that often in nursing, medical practice, or in clinical practice, you're really hard on yourselves and you look for what you can't do rather than what you can do. And actually, what are your strengths? How do you leverage them? How do you bring them to the best, you know, of the four? You know, you might not be the most detailed person, but if you're a really good intuitive big thinker who comes up with great ideas, what is it that you bring to the party, and how does that support you? Other aspect of that is looking for what's missing rather than what's wrong. So what are your gaps? And then from that, after you know what you want, you've checked out the data. What are people saying? What are my scores? What are my, you know, what are my feelings on this? I know my strengths. I know what's missing. What does my learning agenda need to be? Because then you can go into a mentor relationship with a really clear idea of what you want the learning to be. And I would imagine, as a mentor, if you see that learning agenda, that's an absolute gift to you, to know that this person is interested and knows what they want. It then talks about experimenting. So that's kind of designing situations that you might like to explore and then getting on and trying that out. So the experimenting is your pilot, and then your practicing is actually doing the do. So just checking time. So what I have done, and I've provided in the slides, but I'm not going to go through it question by question today because we haven't got time, but you'll get that within the slide pack. Is just a set of questions that you can ask yourself to work through this, and you can kind of just get a bit of paper and do this. Equally, mentors, you could use this in a session as a bit of a script with somebody if you've got somebody who's very stuck and doesn't know where they want to go. So you can see here, ideal self, who do you want to be, using those visioning techniques. The reality side of it, you might explore qualitative goals here with that person. What data is there? I know you guys have data, don't you, in terms of doctors in training, and you get feedback, but what else is there? Is there anything else that you might need to discuss? Is there well-being stuff in there? The other bit is the strengths. So what strengths do you currently have? Don't be shy. Make sure you talk about your strengths and know what they are. And I would imagine that some of your ideal self is already there. So it may well be that you've already achieved aspects of that and where your real self overlap. What's the positive feedback you're getting? All of those type of things. The gaps, it's not what's wrong, it's just something missing. So where's that missing in terms of your ideal self and where things are at the moment? This is where you might explore barriers. So situations you might feel different with, find difficult. What tasks require extra effort? I love that question actually, because it's a really good one. What takes more energy compared to other individuals? And then your learning agenda. So you build on your strengths. Don't just reduce your gaps. Make sure you build your strengths as well. How do you hone those skills? Who else could you possibly involve to get this set up for you? So experimenting, how you're going to do it. How might you possibly identify opportunities to do that? Are they just within your training position? Are they elsewhere? And how might you evaluate whether that was effective or not? And then finally, how do you crack on and practice? So get them into practice, new skills, how are you going to do it? Who might be able to help you with that? And really, it's kind of a constant cycle. And I think it's a really helpful model for both mentees and mentors to use with each other, because I think it works for both harder skills, but it also works for some of those softer kind of personal development and leadership skills as well. So I'm just going to kind of finish up now by kind of talking both to mentees and mentors around what are some of the barriers to mentoring, a little bit of more detail on contracting, and just kind of rounding things up like that. So for both of you, power and authority can be really difficult to overcome, both from both sides. So mentors, you sometimes need to put your badge, take your badge off, okay? And mentees, you need to take yours off as well, so that you're kind of accessing each other as people rather than within within the hierarchy. Be clear about what you do, you know, how you trust each other, and be okay with the fact it might take a little bit of time to build rapport. You don't have to be completely trustworthy or share everything. That openness and that trust does take time to build, and it's something you have to work on. It's an active thing. Obviously, not being inclusive can be really difficult for all the reasons that we've talked about. It isn't an easy topic, but I think as mentors, we should be comfortable about noticing that there are issues happening around inclusion. And equally, mentees, it's about you being able to feel confident that you can share things and work out solutions around that. I think lack of rapport is a reality, and sometimes when options are limited, that can be difficult. But if there is a lack of rapport, it's not that you're bad people or you're not good with people. It's just maybe you just haven't got rapport with each other, and that's okay. Everybody's different, and maybe that's a time to kind of be open and honest and then swap out, and it may be that you'll get a better relationship. Time and opportunity in every NHS trust, I'm sure, is a major challenge, and linking to not enough mentors. I think it's brilliant that you're doing all this work, because the lack of structure hopefully will become less and less of an issue within cardiothoracic surgery. And I do think a non-coaching mindset where it's very much either all about the mentee or all about the mentor can really get in their way. So it's about goal setting, listening, understanding, great high quality questions, and using that coaching structure to give you a good mentoring relationship. And I've put this at the end, because I want you to remember it, and that's contracting, also known as how to prevent problems from the start. So I think as a mentor and a mentee, I want you to both listen to this. So what is your reason for seeking out mentorship, and where are you now? Because if a mentor's got an idea of what mentorship should be and the mentees is completely different, you need to work that out at the beginning and have that conversation. What do you want it to achieve? Where do they want to be? Be specific about how you will work together. So setting of agendas, ethics, codes of conduct, reporting arrangements. Is there going to be any sharing of conversations outside of the mentorship relationship? Is it educational? What is it? And be really clear about that. Get your initial goals and motivation kind of sorted. And that's really up to you mentees to come in with that. It's not for the mentor to go, so what do you want to be when you grow up? You need to have done that work prior to that mentor, first mentor meeting. Are there any practical arrangements in terms of barriers, be able to meet, IT connections, etc.? How do you review the relationship? Coming back to the issue about rapport, and also your confidentiality agreement. So both ways and its limits, which would be the usual limits from a confidentiality point of view around self-harm or harm to others, that you would break those barriers. I think we make a lot of assumptions when we go into it, and my request is don't make those assumptions, have the conversation up front and get comfortable with it, because it is a bit awkward when you first do it for the first time, but have those conversations. And that is me coming to the end. I make a big request that everyone has a little look at the coaching continuum and goes up and down it rather than spends their time in one particular area. And again, I'm happy to take any questions here or after the session. And I will stop sharing my screen. I think I'm on timer mode for you as well.
Lucy, you're fantastic. Thank you very much. You're unlike these cardiothoracic surgeons. You do keep the time. Any questions? Sham, please.
It's not a question, Lucy. It's a comment. I usually at this time can be euphoric because of lots of afternoon and postprandial, but it was an amazing talk. Both of your this thing were amazing, and the way you structured it, and I like the Monster University, the theorem is fantastic. It's amazing concept. It's a amazing way of we are mentors, but some of the concept you today told us were quite useful for us when we deal with sometimes not difficult, but some mentees are not that engaging. Then you have to literally sort of push them in that direction. It's a great guide for us. Thank you.
You're very, very welcome. And it's okay to have structure, because you are all brilliant clinicians, but you may well be accidental mentors or accidental leaders. And this is an opportunity to kind of have those skills. I spend my time doing this just like you spend your time, operating and stuff. So it's an absolute pleasure to share that. I've just seen a comment from Karen about how long is it ideal to run for a mentor-mentee relationship for. I think it depends on the purpose. So if it's for a specific skill, you might have something time defined. But I know that I still keep in touch with one of my mentors from the NHS graduate training scheme. It's more informal now. That was 1998, giving my age away there. But it's I think it for me it comes back to that contracting. And I think it define the purpose, what the goal is, and I think that will tell you how long it is. And I don't know about you, but sometimes mentor-mentee relationships turn into friendships. I've just seen Dan Caradis on LinkedIn, talking about his mentor, Mr. Paul Renwick, one of our vascular surgeons. He's had a complete impact on his life for the last 18 years. And that for me, probably that says it all in terms of the impact you can have on someone potentially.
So you don't think that there is a potential for the relationship to go stale or become just codependent, and a fresher mentor-mentee relationship is better? No.
Yeah, I mean, I think you're right. I suppose it's difficult to say, because I suppose I'm not in I think from a clinical skills perspective, then yeah, maybe that is the case. But I think it would very much depend. I mean, when we coach, I tend to offer 6 to 8 sessions to begin with. And that's probably every 4 to 6 weeks. And we would review that probably halfway. And sometimes people want to continue, some people want to stop. And I think it very much depends on what's needed. I think if it's helpful for the mentee and the mentor to continue, I wouldn't stop that. But you might find it becomes more informal rather than structured. Does that make sense? Yeah, that's a bit of a politician's answer, that. Sorry.
That's Naren, you had your hand up, Naren.
Just to reiterate actually something that Sharman said actually. I thank you so much for those talks, and because I think we get a lot of questions or comments from mentors, mentees about wanting to engage in the process, not quite understanding and being hesitant, and almost therefore not able to reap the benefits of it. And I think it's fantastic for those who are on the course today, and hopefully we'll be able to put out some material for those who aren't. But I think what you've done is given a fantastic infrastructure in what a mentee and mentor could expect and what a mentee and mentor should be doing. And I think it was really powerful. Thank you so much is what I'm trying to say. Thank you so much for what you've been able to convey to everyone that's attended today. And I've heard your talk last time, but it's still fantastic. So thank you.
That's great stuff.
Thank you, Narain. Just one last question about what measures the success of a program. So these two mentorship schemes are being implemented. So what measures can we use to measure the success of these schemes by our society?
I mean,
do you know any off the top of your head? Yeah.
I mean, we have feedback forms, so we do like personal relationship stuff. Does that make sense? So we can actually measure how effective the relationship was, and I'll be more than happy to share those with you actually. So we tend to collect case studies and qualitative things like that. But I know it sounds really daft, but I think I would be really keen for you to ask your mentees, and I wonder if that's something we could support you with, and actually come up with what would be a measure, because I think that from my perspective, it's something that we don't do enough of in OD. We know it works, and I've just joined the there's now a new special group in the British Psychological Society for coaching psychology, and we're trying to almost backtrack on why we know coaching works. Does that make sense in terms of the psychological theories that connects to it? And so I'd be really interested in kind of looking and supporting the society, if that would be helpful. And I'm going to speak to Matt, who is my lead coach, because he's just done his level 7, and I'm just about to do my master's. So maybe this could be my project, so I'll offer myself up.
we don't mind being your guinea pigs.
Excellent,
so,
excellent.
Can we definitely take you up on that offer? Actually, that would be fantastic.
Yeah, no,
to help
definitely.
us to evaluate what we're doing, and because the evaluation will not only reinforce if we're doing a good thing, but also how we can make it better. So that would be fantastic.
Yeah, no problem at all. And if there's anything we can do from an inclusion point of view, I have a really good team who's doing some of that work as well around allyship and training and development. So again, if there's anything we can support with that, then that offer's there for you.
Thank you very much, Lucy. Your present from Narain is on its way. He's footing the bill.
Excellent. Excellent.
Okay, thank you very much again, Lucy. I appreciate it, and we appreciate your slides as well being shared with everybody. And we will hope to see you again in future courses. Keep on moving. Karen, I think she was asking questions, so she's there somewhere. Karen, can you share? Are you sharing some slides, or are you just talking? Any slides?
Yeah, bear with me. Just let me. Can you see that?
That's
okay.
Fine. Yeah. So Karen Booth is a consultant cardiac surgeon in Newcastle, and she is the chair of the SCTS Women in Cardiothoracic Surgery group, and she's just going to try and share with us some experiences of women in cardiothoracic surgery. Thank you, Karen.
Thanks, Hamoud. Yeah, thanks very much for asking me to do this today. Confession here in that you can't really be an expert in this subject, except for the fact that I am a female and a surgeon. And when I was approached by society to kind of take this role on, I was very happy to do so. So it's great. I think everyone who's here today is coming from the same mindset. And really, I guess what I'm going to try and say is just that we just need to be aware that we need to educate quite a lot of people, not just within our own society, but also within this society in which we work in, and also in society in general, because it still unfortunately is an issue, and that's probably why we needed this group to begin with. So just a few facts, because I think it is important to recognise I came through medical training back in 2006, and at that stage half of my degree specialty was made up of girls. And in the UK, women now make up 19% of higher trainees, specialist doctors and consultants in surgery. But you can see that although we start in a really good grounding place, so 54% of foundation trainees being girls, by the time we get to consultant surgeons, actually we fall down to around 12%. And there's a bit of a disparity between which specialty background you come from. So it's more likely to be a female surgeon if you're in paediatric surgery as compared to if you're in cardiothoracics. And really, it's not that long since we had the first female who gained her CCST in cardiothoracic surgery. That was just back in 2001. So just at the time at which I was starting my medical training, June was coming through and actually completing her FRCS exam. So I think that Martin Luther King and a lot of the human rights activists would say the same thing, that you can't really legislate for morality or for fairness, but we can regulate behaviour. Can't change any laws, but we can certainly educate and change the hearts and minds of people. And I think that's hopefully the starting point for where women in cardiothoracic surgery is going to hopefully come from. So it's just an acknowledgement that it is an issue, and then from there it's about what we want to do as a society to take it forward to support people. So the mentor and mentorship scheme that we've agreed to take on, the whole idea of that is that we recognise that that's a tool that we can use, and that we're not looking for, I think Noreen mentioned earlier about positive discrimination, and as Lucy said, we're just looking for some equality. So we're looking to have an acknowledgement that there is an issue, these are the facts that the issue is there, and then it's about what we all want to do collectively as a group to be able to make some positive changes, because diversity is a positive thing and not a negative thing. And although it's separated out into an equality and diversity policy and a female policy within SCTS, in reality we're all facing, I think, the same things, and it's just about being aware and educated to the fact that there are barriers, and then what we can do to hopefully reduce those barriers for people that are coming through behind us. And in my own story, it was really my mum who inspired me to have a career. And as I came through my own life circumstances, my mum was made to give up work back in the 1970s. You weren't allowed to work if you were married. You weren't allowed to work if you had any children. So at certain points in her career, she had her career stopped, and she received some interesting advice about pensions and policies. And my mum worked just for a local bank in Northern Ireland, but was advised not to help with her pension, but to receive lump sums along the way, and her pay was frozen at multiple points in her career. So she also had a mum who was quite unwell, and my mum gave up work to look after her mum when she was 19, so she never made it to university herself. But when I was doing my GCSEs, my brother was doing his A-levels, and we helped my mum get her own university degree, back to work and establish her own career when she was just in her early 40s. And so I've always had somebody behind me advocating that it was really important to have your own independence, your own salary and your own career. And that's where I've always come from, and from my own standpoint. And whenever I went to have my own children in cardiothoracic training, it was my mum who gave up her job so that she could be there to support me full time. I think that's really what it's about, is about understanding that there are barriers, that they do exist, but then we have to have ways in which we can overcome them, and that they'll be very individual and very specific to people. So there'll not be a one size fits all mentality, and that we just need to really educate everyone around us. And that's why I put up this screen with a list of facts, because I think that sometimes it can feel like we're looking for special treatment, and that's really not what it's about at all. I think it's really important to note that when we're being discriminated against, it's not necessarily that people are actively doing so, but that it is an act. So it's making a distinction between people based on their group, their class, or their categories to which they're perceived to belong, and that it can be a really lonely place to be. I'm a mum to 3 kids, and I've watched with my 2 girls who are my eldest, are 11 and 6. It's the worst place to be in the playground when nobody wants to play with you. And I know that being able to make like those social interactions and to have friends can be really, really difficult. And children are hugely discriminatory based on what shoes you wear, what hairstyle you bring to school, what school bag you carry. And I see that quite a lot, with the sort of the struggles of that. You can see that actually discrimination is just in society. And once we accept that, then actually then we'll be able to talk about those barriers. I think we can all say that we're a big fan of Raheem Sterling at the minute. I'm sure before, pre-Euros, there's quite a lot of opinion on whether or not he should have even made the team. But in actual fact, he's been one of those key players that's made it on the team now. And so I find that really interesting, that it's how we perceive people to be. It can be based on the way we were raised, our social upbringing, what our family, religious beliefs are, that can really go on to impact other people. And so I don't actually believe that it's necessarily just to females, although we have obviously separated these out, but actually equality and diversity impacts so many people that we work with. And it's important just to understand that it exists and to educate, and then hopefully we'll be able to help people to come up with solutions to the barriers. And I don't know if you've read 100,000 Hearts, but I think there's some things that are really specific to cardiothoracic surgery, which are just negative. And I think some of the culture of cardiothoracic surgery can be quite toxic. And it always really fascinated me to read about the Denton Cooley and the Michael DeBakey relationship. Just some facts on Denton Cooley. So obviously, we've got instruments thanks to Cooley. We've got a total artificial heart thanks to Cooley. There's so many things where we put surgeons up on pedestals, and no more so than in the specialty of cardiothoracic surgery. And we're all taught about the giants of cardiothoracic surgery. EACS focuses on doing interviews with the giants and the people that we should look up to. And there's also no doubt in my mind that a lot of those are also white men. That's who we look at, and that's who's put on that pedestal. But also, if you just read at the bottom, Cooley and Michael DeBakey had a professional rivalry that lasted more than 40 years. They opened up their own institutions and eventually made amends in a public rapprochement in 2007, when DeBakey was 99 years old, just when he was about to have his dissection, and Cooley was 87. And I think that rivalry in cardiothoracic surgery makes it quite specific then as to some of the problems that we have within the specialty, and can be one of the barriers in terms of why females feel that maybe they don't really want to get that involved or to make it higher up to the top. And I think that rivalry, and we call it professional rivalry, we need to really look at and see what impact that has on patients, what impact that has on training, because it has a massive wider impact on whether or not that's really another topic that we kind of really need to kind of tackle within specialty, that actually will help in terms of that discrimination. We might all want to be the best surgeons, but actually it's the teams that will make the best care for patients overall. What we really need to do is look at that team approach moving forward, and then including equality and diversity within that team will only ever improve the specialty, not make it any worse. I think knowledge really is power. I think it's really important that we understand the problems that we face. So we do need to understand why we don't have as many females that are consultants. That means we need to get some of the feedback work that we've done in the questionnaires that Noreen has sent out. It's really important that we kind of come to understand why people feel that they'll go so far in training and then give up. I think we really do. I mean, you see at the SCTS meeting this year, we had a session on diversity being the spice of life, and that's really what we want to promote as a society. I think that patients and the public really deserve better than the rivalry and competition, and that the important thing is we really excel as a specialty to make it better for everyone who comes into contact with it. And that surely has got to include having as many different cultures, different sexes and types of people, rather than just having the stereotype that we're used to see. And that was all that I was going to say. If that's okay, I'll take any questions, Mahmood.
Thank you very much, Karen. Do you want to stop sharing your screen?
Yeah, sure.
Any questions for Karen from the attendees? I mean, I wanted to know what do you think the more specific obstacles towards women in cardiothoracic surgery, and more specifically in cardiac than thoracic, because there seems to be more women going into thoracic surgery than cardiac surgery. And I don't know if you saw the figures even from my own region, that is obvious. There's a 10-15% more involvement in thoracic surgery. And I think this is replicated across the country. Why do you think cardiac surgery specifically is affected more by this problem? What are the obstacles?
Yeah, I do think it's that rivalry that I was trying to kind of explain, that kind of, I think that competition, that is out there. There's there's a very definite assumption that you need to have a kind of inner resilience that potentially maybe, I think some certainly male counterparts would feel that you wouldn't naturally possess as a female. And I've had plenty of comments in my career to date about, I'll not be able to do it if I want to have a family. I'll not be able to do it because the hours are too long. I'll not be able to do it because I'll not have the ability. I'll not be able to take, a lot of time people will say you can't take emotion out of your decision making. So they will use that to say that, you know, if it comes to tricky decisions and these complex cases, that actually it's more suited to a male. But I think it's just the role models that we see. That's just what we're used to seeing. And actually some of my biggest supporters in my career have been males who have supported me. And so I think it's just about like an understanding that, you know, we need to accept that it's a problem, but we need to encourage and support. There's the natural things like, you know, having children and the barriers that, in terms of what you would need in terms of training. I know that, for example, I couldn't do part-time training. It's very regional specific, but in Northern Ireland, you had to have a female trainee at the same stage of training to be able to go part-time. And so that was a definite barrier. But actually, I think that professional rivalry that you see played out in all of our units at the M&Ms, where it's not patient focused. I think that very much encourages girls down different specialty routes. I'd be really interested to see if you can pull that out from trainees as to why, because the dropout is before ST3, and those facts that I showed, the trainees at foundation level are 50%. It's by the time they come to core that they decide they're not going down a cardiothoracic avenue. So what is it that stops that? I mean, I've had comments from female medical students and trainees who said, I just wouldn't do what you're prepared to do. So the long hours, the anti-socialness, they not being able to go part-time, and also that rivalry that they see, they just feel that's just not suited. And I think if we can take that out of it and much more of a team-based approach, and a patient-based focus approach, I think actually we would be able to counter that. And I mean, that's just my opinion. I'm not an expert on it, but it would be very interesting to see what will come out of the feedback within our own society. But I think you'd need to take it more to trainees in surgery in general, so take it to the colleges and find out what that barrier is that drops that percentage, because it happens before they join ST3.
I thank you very much for that. I know that less than full-time training has become easier now, and they don't have to go through the same hoops that you've gone through to get somebody exactly the same, and they can choose 50%, 60%, 80% training. So that has become easier, and maybe that will allow more women to be involved in surgical training. But also, so you think the rivalry is more in cardiac surgery, but it doesn't exist in thoracic surgery? Is that why more women are going into thoracic surgery?
I'm really not. I can't, to be honest with you, there must be something that is much more of a team-based approach in thoracic that there is in cardiac. So, you know, I know why I personally chose cardiac surgery, but again, I'm reluctant to use my own rationale to explain a wider issue. I think we'd need to know from feedback as to why that is. It's definitely true that there are more females that choose to go into thoracic, and there's no doubt that, you know, it should be more regulated hours in terms of what you needed to do out of hours and things, and there's more thoracic surgeons in general, isn't there? So probably more of a team-based approach.
Okay, thank you very much, Karen. Any questions? Sorry.
It's because thoracic surgeons are such nice people.
Okay, that's where is your evidence for that? Can we see the evidence for that?
Randomized perspective.
There's no evidence for that. I'd be interested to hear also from trainees, both female trainees and trust appointed doctors, about, after these two talks, about the challenges that they might have faced. You don't have to speak up, but it'd be lovely if you want to speak. But at least if you put it in the chat, obstacles that you have faced, or problems that you have faced as a woman in cardiothoracic surgery, or as a trust appointed doctor in cardiothoracic surgery, obstacle for your progression and taking cardiothoracic surgery as a career. So do please contribute with your own experiences, which we can share and discuss.
I think there's one question there. Yeah, go ahead. Oh, sorry, Narayan, sorry.
I'm just going to pick up on a couple of things you said. I think that's one of the powerful things we will get from the survey, because the whole point of the society wanting to engage and make this agenda important is to say, what are the issues? Why is that dropout? And what can we do to make a difference? So if some of it is because the infrastructure is not there, say, to support less than full-time training, we've got to demonstrate how it can be done and how that can be rolled out to other programs. And I think it is really important that people engage with us to say, these are the issues, this is what you can do to change, and then we will have a voice to try and support everyone, because the whole point of everything that you've said, that we've said earlier, is the workplace, the care that we deliver will be better if we allow everyone the opportunity to progress in the specialty. And that's all it is. We've talked about positive action, quality of opportunities, and that is all we're trying to do. So what are those barriers? What can we do? And please communicate, contact us, let us know what they are and how we can help, whether it's through the survey, whether it's now, speak up, or whether it's easier to do it indirectly, email me or Karen, and we're happy to try and take this agenda forward.
So there's a question for you, Karen. How did you deal with those who doubted your aspirations or stand in your way?
Yeah, good, really good question. So I have skin that's maybe about 20 inches thick. That's probably true. I've got probably a little bit less resilient in the last couple of years, have to say. But yeah, I think you very much put all that to the back of your mind. And I have to say that no matter how many times I was told I couldn't do it, that made me just want to do it more. But I still believe that you shouldn't have to go through that, that it should be, you know, a well-structured pathway, that if you want to do it, the avenue should be open. It never failed to amaze me that we weren't trained in my day in cardiothoracic surgery, we were allowed to do, and so it was those who had the ability to do that got ahead, you know, in terms of logbook and what you could achieve in terms of in cardiac surgery. And I think that to have structure put in and to allow everyone the opportunity would only ever improve diversity and would only ever improve the specialty. If we can just take some of that competition away and we can put patients really at the focus, then I think actually we would achieve so much more.
Thank you very much. And Joe, we will want to see that double-blind evidence that you have supplied, please, in writing. Thank you very much. We'll move on to our next. I think there's a mistake with the timings on the program, but it helps us to get back to a schedule. Thanks, Karen. Our next area that we're focusing on today is obviously trust-appointed doctors, and Zahid and Ram have kindly agreed to talk to us to discuss what they think are the issues there that could affect progress and success. I'll hand over to you, Zahid. You're starting first, yes?
Thanks very much, Mahmood, for giving me the opportunity on that mentorship program. And thanks very much for Naren for organizing this wonderful mentorship and mentees program. And I'll be delighted on behalf of SCTS that myself and Ram will take this further, and with the help of Education Committee as well as the rest of the SCTS to move this mentorship program forward. So I would like to share a screen. So just to go through the challenges in the specialty. So first thing is that I've been giving a talk on the trust-appointed doctors' experience in cardiothoracic surgery. So what are the training challenges? The first thing is, I would say the prioritization is difficult and challenging because of the working time directive and unit requirement. So with my personal experience, I gone through a Article 14 route, and I will see this one is one of the major hurdles or barriers when there is different unit requirements in terms of intensive care, high dependency unit cover, ward, theaters, mixture of trainees and non-trainees, and their level of experience, and also of the limited opportunities during the training. It make a prioritization is really challenging for a trust appointed doctor to find a place where he can progress. The next problems or barrier comes up is the limited recognition of seniority of the middle grade surgeons. So the middle grade surgeons, which I say the trust appointed doctors, varies from a junior level, middle, or on a senior level. They will be a permanent member of the staff like staff grade or maybe clinical fellow or trust fellow grades. But when the recognition comes on their level of experience and seniority, that will not be considered into the service commitments and unit requirements. If they have a shortage of cover in the ward, they will put any trust appointed doctors to cover the ward without understanding or knowing that he is more capable of covering the other areas rather than just the ward alone or vice versa. The second thing about the limited recognition is that because there is no structured program in terms of middle grade doctors, it's also difficult for the trust or the units to understand the level of experience of that particular trust appointed doctor. The third thing comes up, and it's very challenging for a trust appointed doctors. And in cardiac surgery, we have to move from different units to gain specialized experience or different types of exposure, so that when we will be independent, we will have all those experience and expertise to perform our operations well and looking after the patient. But when a trust appointed doctor moves from one unit to another, then there is no way he will find himself at the appropriate level of his experience and seniority, because there is no system in the units or in the teams to acknowledge that and put it at an appropriate level. Usually what happens, if the contract is for 1 year or 2 years, it will take about 6 months to a year for that a particular trust appointed doctor to recognize himself and his competencies to that particular unit. If he is successful and his contract extended for another year or 2 years, then he will have the opportunities to train himself and progress in that particular unit. If he has to move from one unit to the other within 6 months to a year or on a short time afterwards, then the challenges are more for that trust appointed doctors. Then the next step comes up, the operative exposure, which as a cardiac surgeon, I feel it really hard and challenging during my progression in the career. First thing is that as a trust appointed doctor, you don't have any curriculum based approach for training. It's your own learning, your own objective, moving from one unit to the other, and making sure your trainer, your colleagues, the management, and the unit recognize your potential and give you the opportunity to progress. And if there's already a national trainee there or more experienced team already there, it will be really difficult to cross that barrier and find a place for operative exposure and training in cardiac surgery. Then also appraiser is a process, we say that will have a defined professional program plans, but as a cardiac surgeon or as a trust appointed doctor, it's really hard to make a well-defined plan and after 6 months or a year to reach to that level that a trust appointed doctor will happily say that this year I have achieved my goals. And also because of the factors I mentioned, that less structured assessment of level of training and also the progression of competencies in the specialty, the barriers for trust appointed doctors are more and more in the specialty. I give my own example that when I was moved from a SHO level to registrar and from a registrar to a senior registrar level, it takes me a lot of effort to put me in a place that I will be getting operative exposure and progression. In both ways, I wasn't be well supported because of the system or the unit, as there's already trainees want to do more, and also the unit requirements was different. Then there is also challenges for a trust appointed doctors on getting FRCS exam because there is no recognized pathway. When I was going through FRCS exam, there was a challenge to get the referees for the exam as a non-trainee. And then also getting progression in the educational activities, in research, audit, quality improvement projects. You need to have your own initiative to get progression in this specialty as a training, as a trust appointed doctor. And similar issues with the funding, taking leave to attend the courses required to progress in the career, as well as going for the conferences. So in terms of challenges, the educational challenges, taking exam and then how to prepare exam, what are the areas need focus. So as a trust appointed doctor, you need to go extra mile than the others to get these milestones. In terms of the next step comes up, if you've gone through an adequate training, you get your FRCS exam, and then the question comes up for Caesar process. And nowadays, the Caesar's application process is more structured. But when I got through my process, it wasn't like that. My first application consists of 1,800 pages. And that was the logbook for more than 10 years, and also including all the educational activities in the last 10 years. And to get it validated and then sent to GMC for application, it takes me more than a year and a half to prepare for the Caesar's application. And on getting support of exam, as I mentioned, and also on the Caesar, the support from the referees and local management and your colleague is crucial. And how to cross that barriers and getting into a stage when you get successful Caesar's application and become an independent adult cardiac surgeon is not easy task. And I hope with that program, which we started with SCTS, to reduce the barriers in training, in education, in exam, as well as in the application process. So I will leave the next part of the talk to my thoracic colleague Ram to see how he thinks how to deal with these challenges. Back to you, Ram.
Thanks, Zahid. So, Zahid, you've got to be sharing screen and continuing from there. You've got all the slides with you. So I'd like to say at the outset that with the fact that this is not a magic bullet, it's something that it's looking to move a few obstacles out of the potential path towards success. And the fact that Narain, Simon, Mahmood and Sham have talked about this, Sri and the rest of the executive have spoken about this, recognized the problem, and openly are looking to address the challenges faced by the very significant part of the workforce, which is trust-appointed doctors. And I'd hazard 50% plus, and Mahmood or Sri can correct me later if you've got numbers, but I think a good proportion of the workforce currently in cardiothoracic surgery would be trust-appointed doctors. The problem we have along the headings that Zahid has already alluded to are in about 3 or 4 categories. And the problem is that the operative experience is a fixed volume. So you can slice and dice this cake, and the more the number, the thinner your slice. So with EWTD, what was probably 8 pieces is now obligatory 16 or even more. So it is a problem. It is a real problem. There is a drive, as a lot of you will know, to try and increase the exposure of national trainees to 3 days of theatre to, again, counteract the reduced times, the reduced time in the specialty, and the reduced time, the 48-hour EWTD program. So how can you get a meaningful slice of the cake? How can one, as a trust-appointed doctor, get a meaningful slice of the cake and not feel aggrieved? I think that would be the main thing. The next slide, please. Zahid, I think you have to move for me. Thank you. So I would suggest that one of the things in this mentor-mentee program, which has been set up, is a big step forward in having somebody guiding you, somebody to talk to outside. And I liked Lucy, I know is not here, but I loved her presentation, which gives us so much structure and so much guidance. And she very elegantly put it, whilst we are jobbing surgeons, she's the jobbing educationalist. And I think if we marry the two up, we'll hopefully deliver in this mentorship program. And I think trying to establish in writing, using the ISCP, I call it the ISCAP, but using the ISCP, if you're a trust-appointed doctor, there's no reason why you can't pay the fee and get in on the ISCP. Insist on having a learning agreement, which I do with every one of my trainees or otherwise. Have the learning agreement, set a realistic expectation, and then make sure you go for your interim meetings. I think that would be a powerful first step forward. And I don't know how many people in this audience today do that on a regular basis. And if they aren't meeting the expected goals, then they have a piece of paper to go back to and say, this was agreed, why are we not reaching this? And just because a trust appointed doctor is not on the training scheme doesn't give them less right to ask the question. And that is important to recognize. The second thing I would say is that appraisal is mandatory, and use that as a strong tool. So there is an educational component in that as well. And if the appraisal is used as a tool with the logbook, again, the trainer and the consultant has a responsibility to the department and to the trust to make sure that these are followed. There is an opportunity to set out clear PDPs, your personal development plans. And this could include, effectively, this could include things like wanting to go to a meeting. If you say San Diego in summer, and I'd like to just drop in across the border to Mexico, that might be stretching it a bit. So maybe keep it modest and say, I'd like to attend the Birmingham review course because I'm going to prepare for the FRCS CTH. You've got a clear objective, and that's realistic, and it is a few £100, but somebody could spring for that. Use the tools at your disposal. Make sure it is a lot of paperwork, it is boring, but as Zahid has alluded to from personal experience, and I'm sure many people will relate to in the room, it's not an easy path for anybody. And as a trust appointed doctor, the hurdles are a little bit more for sure. But it's important that you take action. Inactivity or feeling sorry for oneself, being the victim in that dramatic triangle, is not going to help you. So use the tools at your disposal, get your PBAs, get your WBAs, and show Mr. Lubani when you move to his firm that you can do an aortic valve at a level 4, and that's what Mr. Kale has just said. And Mr. Lubani will sit in his room and have coffee every day, that he has an aortic valve, won't you, Mahmood? So, and I think so. That's the important thing. On the thoracic surgical side, I would say be proactive and want to go to MDTs. MDTs are the most active learning scenarios that I have seen, and try and get into clinic. Zahid was mentioning how trust-appointed doctors often get put into the ward cover. But if you're proactive and you interact with the rota master and ask, the rota master can't deny it week on week. And if that does happen, then you've got your consultant. And if that still happens, you've got your mentor to go to. So there is a line to go down. Keep it local, sort out the problems, but there is a way to do it. And once you sort the things on this slide, the next slide, please. You do have the fellowship exam, which is going to be your pinnacle. And for the fellowship exam, I'm sure Sri, who's coming up next, will be mentioning the courses and the teaching aids that are going to be opened out now to the trust-appointed doctors as well, in addition to the NTNs. Professor Inescu has been a most generous benefactor, and and there are many, many people in the SCTS who have benefited. And the one thing, my plea to everybody who's on, and then your friends, would be become a member and you can reap the benefits. It was very disappointing to see that at the last time one of the scholarships went unapplied for, and I'm sure Sri will back me up on that when he talks. It's easy to sit back and say this is not fair, and like Lucy said, if you keep saying this is not fair, it just means perhaps you've not got involved as much as you should. That's not always the case, and I'm sure there are genuine examples of people being involved and not being recognized. So simple things like a little quip, QI, quality improvement project locally, a little audit locally, a small paper, all that, put your name forward, go ahead and do it, get involved in the department outside of just being there to look after a patient and operate. There's so much more to your job that it'll actually make you enjoy coming into work. The next one, please. So I think the foundation of this entire mentorship program is to hold hands. It's to guide you. It's not to spoon feed. And I am very, very keen that it's not taken as sitting there and being told ABC. Like, again, I go back to Lucy's talk. It's not there for the mentor to tell a mentee, this is how things need to be done. It's for the mentee to share, it's for the mentee to vent, and it's for the mentor to guide in whichever way appropriate. And I think every one of you, as Narain just mentioned a few minutes ago, it's to give equal opportunities is for positive action, and the finish line is in sight, but you've got to persist. There will be obstacles, and Lucy said her role model was Wonder Woman. I love Wonder Woman, but not for the same reasons that she does. My role model is Yoda, and Yoda often says failure is a great teacher. So don't trip and stop at every failure. Go up to the next one, please. Next slide, please. And I think if we keep going, these are Maslow's hierarchical needs, and everybody really would love a sense of belonging, a sense of recognition. So after the basic needs are taken care of, security is within a job. If you feel you belong in your unit, you feel you're respected and recognized, your experience is recognized, then you really want to become the best person that you can be. And if that umbrella goal is to be the best cardiothoracic surgeon, well, you can knock Mr. Labani off his perch then. So, but in the meantime, I think it's really important to reinforce from the SCTS standpoint, this is not lip service. This is true, genuinely felt, and we're out there to help. Everything, unfortunately, has to be done at trust level. The SCTS strongly recommends, suggests, but unfortunately, at the end of the day, it has to be delivered at a trust level, and we'll be there to support. And I'm a movie buff too, and that's a pretty impressive cast of the Three Musketeers. So remember, all for one and one for all. Thank you.
Excellent. Thank you very much, Ram, for a very comprehensive talk about the issues faced by trust-appointed doctors. And just look if there's any questions. Hopefully there's one here on the ISCP side. When a trainee registers their placement, the TPD validates their placement, and then one sets up the learning agreements with the assigned educational supervisor. How would a trust doctor get their placement validated? Or are these provisions to set up a learning agreement without getting the placement validated? Are you aware of the problem?
That's a good question, and I really don't know. We have to ask the chapter.
The way I have dealt with this here locally is that anybody who does register on the ISCB who is not a trainee, they do send me, because I'm the TBD here in Yorkshire, they do send me the link to validate their placement as their TBD. So I think what would be worthwhile is having a chat with the TBD in your area and asking them, telling them that you are going to register in ISCP, and they will be getting a link to validate their portfolio, and then they can do that for you, and that will resolve this issue. But then use it as a trainee would use it, and take maximum advantage of it using the PPAs, the work-based assessments. It's all evidence that you can use in the future for your CSER application or otherwise. Zahid, you have your hand up.
Yeah, so I completely agree with you, Mahmood, what you have just said. Recently, I have a trust-appointed doctor who want to go through ISCP's site route, and I exactly did the same. I requested the TPD to approve that and validate, and that is counted towards his experience.
Sure, thank you. So, and this is a problem that has been raised to me by trainees, and I understand the challenge. You explained it very eloquently with the cake, and the more people wanting a slice, the smaller the slice is going to be. But how do you think we're going to be able to deal with the challenge of increasing the trainees' access to theatre and still giving sufficient access for trust-appointed doctors?
It's difficult, isn't it? I mean, there is no. I'll love to hear what Zahid says. The one option which we've spoken about is have two trainees scrubbing on a case, and if maybe a junior trainee takes the mammary, puts the pipes in, and then the senior trainee does the bottom ends of the consultant scrubbed in, and then takes the junior trainee through the top ends. But that puts the consultant, and one of our consultants commented, they said that one of our junior consultants who's a good surgeon and a keen trainer said, that puts me under so much pressure and it slows things down as well. So I think we can talk about it in theory, but in reality, how can that be delivered? It needs to be seen. Because my consultant colleague felt he was keen to do it, but felt that it added so much time that often the afternoon case was having a problem and so on. And then you start to pick and choose and can't deliver. I think that's one option, whether you can do bits of a case and slowly build up your volume. And the second thing is, I like the future vision. Not every trust appointed, if every trust appointed doctor in the workforce asks themselves, what does the future mean? And if everybody's answer is, I see myself as a consultant lady cardiothoracic surgeon or a male thoracic surgeon, whatever, a consultant position, then the plan needs to be different. But if some of them feel, I'm happy to be a workforce provider and I don't wish to progress, then the answers are different. So I think that would be a good starting point to ask, where do I see myself at the end of the journey? Thanks, Ram.
Naren and then Zahid. Naren, please.
Thank you both, Zaid and Ram, for the excellent presentations and highlighting some of the issues that currently exist in cardiothoracic surgery for trust-appointed doctors. The Society are aware of these and are taking big steps to try and address some of them. So the first is about the equality or inequality in the education provisions, and I'm sure Shri in his presentation next will talk about how we're trying to expand the education course portfolios, increase the opportunities for fellowships, make sure that all the resources we have available throughout the Society are made as equal as possible in a, won't necessarily happen overnight, but we're making progress towards that. Second thing is the big question you talked about is opportunities for training and operative experience. Part of the big drive of the Society at the moment is to try and transform how the cardiothoracic workforce functions. So yes, you are right, the pie is a fixed size, but if we can enhance career progression for NAHP, nurse and allied health professionals through advanced clinical practitioner roles, we will then free up the trust-appointed doctors and the nationally appointed trainees from service provision. And then that will allow them to spend more time in the operating room. Operating time is still fixed. And what we do by allowing a lot of the service provision but to be provided by non-surgical or medical practitioners, it then allows all the time to be concentrated on the trainees. So it may mean that we need less trust-appointed doctors and trainees in the system, but those who are in the system will have a lot more time to be spent in theatre. So the initiative of the Society to try and push trainees to spend 3 days in theatres isn't just for the NTNs, it's for the NTNs and the trust-appointed doctors, because we value, as you said right at the start of your presentation, the really important contribution that trust-appointed doctors give to patients undergoing cardiothoracic surgery. We have to support them, look after them, help them develop their careers and progress them. So it's trying to understand what the issues are and then put in a vision, a strategy moving forward on how we address that. So the strategy that we are putting forward will allow the trust-appointed doctors who are appointed to spend more time in theatre to gain that training recognition. Zaid, you so clearly articulated one of the big issues is the support while they're in there. So recognition of what stage they are, early phase 1, phase 2, phase 3 of the new curriculum and the terminology. And that is so important for trust-appointed doctors moving forward. If we can categorize them into phase 1, phase 2, phase 3, they can have appropriate learning agreements and targets and goals set for them. And then can progress. And we talked about non-resident for trainees or middle grades. Those opportunities, therefore, to do emergency work will be afforded to them. So it is trying to recognize that, and aligned, associated with that is having the monitoring system, which is the ARCP ISCP program. So I think it's really important for all trust-appointed doctors to have that to back up the understanding of where they are in phase 1, phase 2, phase 3 of the new curriculum. But it is really important for the society, and we recognise this, that we support all the trust appointed doctors, and hence the mentorship program, which is why we're here today, is one of the steps in that progress. But thank you both for the work that you're doing to make this happen.
Thank you, Narain. Do you have a comment, Zahid?
Yeah, what Narain have said, I absolutely agree that the transformation for the cardiothoracic services are happening, and we like more roles by the allied health professionals in service jobs. But the other things, as you mentioned about the operative training and overall training, is that what we need to encourage the local trust or local units will make rather a consultant or a trainee, a group of trainee, a trust appointed doctor or a trainee with a trainers, so that they will maximize the training opportunities in theatre. And as Narain mentioned that in future, maybe we need to appoint less training doctors, whether it's NTNs or trust appointed doctors, and give more roles to allied health professionals to do of service jobs, to move the specialty forward in terms of operative experience and progression.
Thank you very much. I think Mr. Kendall is going to talk later on, and this will be the thrust of his talk about the new proposals by SCTS for the workforce arrangements. So thank you very much for that. Is Shri on the line with us? Shri? I haven't seen him earlier. Emma, are you with us?
Hi, yes, no, Shri isn't on at the moment, and I think he was running a clinic, so I'm not sure if he was able to attend.
Do you have a contact number for him to
Yes, sure, I'll give him a call.
Meanwhile, we have Rana Saeed with us, who's on the call. Rana is a consultant in Oxford, but he is the chair of the exam, the FRCS Cardiothoracic exam, and he's kindly agreed to, or suggested to, update us on some changes. Can you hear me, Rana?
Yes, thanks very much, Mahmood. I say how much I'm enjoying this afternoon's programme. I thought Lucy was excellent, and the other speakers have been very good indeed. But there has been some comment about differential attainment. You mentioned it in your slide, and I think Zahid mentioned it in his. The differential attainment in the exam for NTNs and non-NTNs, NTNs and trust appointed doctors. And the exam board have recognised this, and it is the only significant discriminator. When you look at candidates, there's no difference according to gender or English as the first language, or where they have qualified. It is whether they are in training, NTNs, or not in training. And one of the problems has been that in the past, or currently and before, there were actually different entry criteria for the exam for NTNs. And one thought is that non-NTNs have been put forward for the exam, have been allowed to enter the exam when they weren't quite ready and hadn't quite reached the standard of NTNs, who of course go through a very structured program, as we've discussed. And so from 2023, there will be harmonized entry criteria for all candidates, regardless of their training status, for the Part 3 exam. And the reason why it's 2023 is that candidates need to be given 1 year's notice. And so these will be introduced from the details are available on the JCIE website now. But the main changes relevant to non-NTNs are that MRCS is now mandatory. There has to be a minimum of 1 year working in the United Kingdom or Ireland with sign up to ISCP. And the advantage and the importance of being registered with ISCP is that there should be demonstration of progression against various competencies referenced to the curriculum on ISCP. And then finally, the principal referee must be countersigned by a Director of Medical Education for UK applicants or the College of Surgeons in Ireland for Irish entrants. And that mirrors the role of TPDs for NTN applicants. And our hope is that by the slightly more rigorous entry criteria, we will ensure that only those candidates that have reached the right standard and have a good chance of passing the exam will come forward to be able to get through. Because the worst is that candidates apply for the exam and are allowed to enter before they're ready, and therefore use up some of their chances before they were actually had enough experience and knowledge.
Thank you very much for that, Rana. So what you're suggesting is that although both groups have been signed off for the exam, it is that signing off process that was the major problem and putting the non-trainees at a disadvantage.
I suspect that is one factor. And of course, looking at this the other way, it shows that the work that Narain, Sri and everyone else with the society involved with the training program we have for NTNs, it has been very effective. And that's why the current initiatives to improve the training of non-NTNs, the trust appointed doctors, are so welcome. So this is thought to be one factor, and by making sure that the entry criteria are the same, that they are signed off when they should be at the same level, we hope that will address part of that differential attainment.
Okay, thank you very much for that. Thank you for your contribution.
Thank you.
It's very much appreciated. So our next speaker, Mr. Rathnam, is not on the line, and unfortunately he's not contactable. And Megan, she's not due for her talk until 1:15. So the only thing, if Sham, are you still with us? Sham? Mr. Kolbekar, can you hear me? Sham? See if Mr. Kolbekar could give his talk now, and we will try and contact Shri as we go along. I'll see if I can bring.
Mahmood, the other option is to go to the coffee break a little bit early and then.
Sure. Yeah, Hi Sham, are you there to give your talk now before the break?
Yeah, I can. Yeah,
okay,
sure.
Right. Let's get you. Yeah, because Megan is not coming back till 4:15, and if we manage to get Shri, we'll fit him in the afternoon. So, Mr. Kolvekar's talk. Can you hear me now, Sham? Okay, so that is Sham. Can you? We can't hear you, Sham. You're muted. Yeah. Hi, Sham.
Hi, can you see it?
We can see it, but it seems to be magnified. We're not seeing it as proper slides.
Go back again and do it the usual version.
Yeah. So Sham is one of the other mentorship leads that have been quite vocal and supportive in developing mentorship across the SCTS portfolio, and he's talking to us today on Zoom power. We've all become experts at Zoom and other virtual platforms, but he's going to talk to us about Zoom Power, the role of web-based mentoring, a new initial approach. Thank you, Sham.
Thank you very much. I think
we had your slides, but we've lost them now.
I'll share it again. Okay. There you go. Can you see it?
Yeah, but it's not in. Yeah.
Okay.
Perfect. Cool.
Okay. I think the Zoom Power is what I said is because since COVID, in the Trump's word, China virus affected us, taught us a lot of things. There are a lot of bad things. A lot of people died prematurely, but we learned so much communication. I used to spend hours and hours traveling around for MDTs, which has disappeared. Clinics disappeared, follow-up disappeared, and for good. I think patients like it. Patients love it because they don't have to get dressed up, catch 3 buses and come to us. And it has improved really well. So I thought, why not mentoring should go along in a similar route initially? Then, of course, nothing to replace face-to-face, but this one. So initially, when you need a mentoring, you could develop a way of guide assistance from the meeting, talk to mentee, any web-based. My personal feeling is we don't even need a special app for it. You can use a MS Team where you can create your groups, and those groups can be your mentor group, and you can communicate with them. I have a similar arrangement with my medical students whom I supervise, and we created these MS Team groups, and then you can have a group together and talk to them, or you can individually mentor them. So that facility can easily, we don't need any special system. We already have, and other thing is with all have NHS emails, so it worked out well. So conventional learning is changing quite a bit. You must have seen some videos from up north. Joel Dunning was doing some robotic remote surgery from a kitchen, and actually it worked. So I think there are things are changing. I think thoracic surgery eventually will be from a home. A couple of guys will be staying in the in the theaters and put arms, and they will be doing all the operations. What I mean is, web has taught us a lot of stuff for mentoring. Mentoring is a communication. Can you imagine you can access any time? Otherwise, to book face-to-face, you need both the people to have a time. Then you need to have a space, and a lot of from modern NHS, I think, I don't know what up in Hull people, I heard Labani has 3 offices, each for other, even in odd day offices. We have no offices. There is a desk barely shared, and even the big Papworth lost their offices. So what I mean is there are no spaces, dedicated spaces to spend time with our mentee and mentor. So I think web-based becoming a good idea and a good solution. So COVID has taught us a lot of things besides staying safe and vaccines. Learning became very easy. Mentoring should be becoming easy. So I think COVID disrupted everything. And if you see, medical school had a Moodle software, and they were doing all the lectures. Students used to go back and catch up. It's all recorded, and they were doing it. And now it's becoming much easier. It's adapted. You can synchronize this. And MDT, you don't have to be based on one person. It can be everywhere. So I think we learned a lot from pandemic, and we got better. The innovations are coming. Software platform. Look at Zoom, which didn't exist before pandemic and became very good. If I'm a conspiracy theory believer, I said the pandemic was started to sell a Zoom, but which is not true. But what I'm saying is, it is how it was worked out on it. But we don't have to have a Zoom for mentoring. You can use any platform. But my personal feeling, education and NHS, it is much better to do that way. So as I said, the MDTs are now virtual, improve the attendance. Majority of job interviews, like you choose your colleagues on that. And I think we had a whole webinar on SCTS annual meeting was that. So I think we have done it, and we should do it for our mentoring. If you listen to Lucy's talk, both the talks, she gives us so many good ideas to work on. And I think main advantage of mentoring through the web base is quick to set up, little time wasted, and only thing I feel is they need to have a protocol. You need to have a SCCA template so that it's done in the rail of SCTS, and then the records can be kept, can be recorded, and it could be confidential. So I think web mentoring is going to come. It's going to get better, more useful, and flexible. You can do it on a weekend, even if you're in holidays, weekend, you can. Basically, what you do is you discuss the cases, if you want to, what the approach to the cases, how you treat it. Everything can be done through the web-based. Eventually, you need face-to-face seeing and talking about it. But otherwise, this works out really well. You can match it up with senior to junior. You match it up the personality who wants to take it on. Mentors could select how many you want and have a regular schedule to it. And you can build up a pace. I personally feel web-based mentoring, if you're doing it in cardiac surgery, you can discuss the cases, good days, bad days, how do you manage it? How do you manage a clinic? So you need to learn from your mentee what his issues are, how you can solve it, and it's much easier by talking about it. You can share a skin share and show the angios, discuss how the approach is going to be. Only thing you can't do is that you can scrub and help them, which probably we'll have to do it at some stage. But otherwise, the initial start, this should be the best approach. I think on this it will be comparatively very low cost because hardly any cost. You're giving your time, and it will be very helpful to support. And you don't have to disrupt your routine. Like today we have an audit day going on parallelly some stage. Whenever I need input, I can contribute to it. And the same way, if you even have an operating day, when you have a break in between the cases, you can. Same for a trainee, if he's done an on-call and next day off, he can use that. So it sort of makes it more flexible. So challenges that we need to have uniform guideline, what we do in mentoring, what level, depending on is a trainee mentor or it's a consultant, junior, senior consultant, or the mentoring for issues the other consultant have. There should be do's and don'ts, and need to standardize. You need to have finite. You cannot just have a little chat in a Zoom jolly. We need to have a reasonable standard of what we do because it can be recorded. And you need a final verification from the SCTS and also trust where the doctors work, because mentoring will be a part of your job description in some of the places. And that's why it need to have a verifications and also have approval from the trust where that person will be employed. Other challenges is, of course, internet. But I think it's getting better. It's fantastic. It's getting much, much quicker. The 5Gs have improved connectivity so well. But difficulties sometimes with most important thing is if you use Zoom and other thing. It happened to a colleague of mine. She was doing some presentation and somebody asked for access and there was all screen pornography or something. Somebody hacked the Zoom. So that's why the confidentiality encryption has to be very important, because if you're discussing patients or cases, then it's important that it's kept confidential. But otherwise, these are the challenges we can overcome. Now, the mobile phones and iPads and computers getting so good and better with a good platform, these challenges can be overcome. So I think web-based, but sometimes it's difficult. If there's a very shy mentee or have issues, and sometimes it's difficult if they have a communications issue, then probably we may have to work on that. But otherwise, as an initial beginning, we should, based on web-based, we do it for medical school anyway. And I feel we should do that for our trainees. But some other complex challenges we must have to do face-to-face, sitting in a room together or in operating room. So traditional mentoring is always there. It will never replaced, because we are a human and we like touch, sense, presence. But technology will make it much easier and streamlined to help. It helps us also. We learn from our mentee, and the mentee learn from us, and the web-based will be better. And I personally feel we don't have to do any much hard work than creating the groups in MS Team.
I'm fine. I'll just do whatever I'm asked. All right.
Simon, you're mute. Yeah, thanks.
So anyway, I think it was just a short talk. I just wanted to introduce this idea. I think it's already there. We just need to put through our group, and more. We can create a format, passes through SCTS, that it is the right format we're going through, so that it's standardized way we can deal with our mentees.
Thank you very much. Thank you very much, Sham.
Stop sharing now, so people can come join us.
Have we got any questions for Sham, or any comments on if anybody's been using the technology for mentorship meetings? Please put your comments either in the chat, or you can unmute yourself and speak. I certainly find virtual platforms much better now. I was able to attend a meeting that I would have had to go to in London, and one in Hull, and one in Leeds in one morning. And you don't have to travel anymore. Before all this, you'd have to choose one of the meetings to attend. So it has made life a lot easier, and I'm sure it's here to stay. And the only, as you say, the issues is safety and confidentiality might be an issue, but I'm sure some of the platforms are more secure than others. Thank you very much, Sham. We're going to take a break for 10 minutes. We will be back at 8:20, and we will have Megan with us, who's just joined us. We'll make sure everything is working order when you come back at 4:20. Thank you.
Thanks, Mahmood. Sorry about that interruption.
That's no problem, Simon. You'll be after Megan.
See you at 20 past.
See you. Thank you very much. Thanks. Hi, Megan. Can you hear me? I can't hear you. You're muted.
Yeah, no, I've unmuted. I'm not used to using Zoom. In theory, I'm doing something which I could get in a lot of trouble for, because we're not supposed to use it at the college. So
I think, Emma, you're still with us. You're going to do the slides, or are you going to do your slides, Megan? Or?
Well, I can try and share my screen.
Try and share your slides.
Okay,
with us.
bear with me. Share, right, okay. I don't know, has that worked?
Yeah, perfect. Do you want to put it into slideshow?
No. Oh, so you've got it, have you? Right.
Yeah, I can see it, but it's the normal view with the slides on the left-hand side and only.
Yeah. Oh, here we go. Slideshow. Begin from beginning. Yeah. Okay, yeah, that's okay. You can see that and everything. Okay. Okay, Emma, I should be able to do it. The one thing I can't see is if there are any questions, Mahmood, sorry, would you actually we get the people to, and then I can answer the questions. It's just that I can't see the chat slide.
No, we can do that. I can do that. That's no problem. In the middle, we can do that, or we can wait till the end and do all the questions.
Probably best to wait to the end. That's the thing that's easier for me. I'm just
perfectly all right. So your slides are working. That's fine. Do you want to unshare them for the time being until We're ready. And
I'm scared that if I do that, I'll never get them back. Seriously.
That's fine. Fine. Stereo, I'll just go back to the beginning to your first slide and leave it.
Yeah, I don't know where. Sorry, I've lost my I've lost the thing on my screen. I can't see the slides on my screen anymore.
Oh, we can still see them. Yeah.
You can still see them, but I can't see them.
Okay. Megan, if you minimize Zoom, that might bring up the PowerPoint behind it. Sometimes it does that.
No, that doesn't seem to have done it. In fact, that's just got rid of everything and I can't see anything at all.
The icons at the bottom of your taskbar, do you have any icons at the bottom that you can?
Yeah, but none of them relate to Zoom.
Right, okay.
Right, okay, so that's me. I can see me back, but what I can't do is, God, I think I'm going to have to leave the meeting, and I don't know what I'm going. I can't even shut it down, to be honest. Okay.
Okay, I've stopped sharing for you, Megan.
Oh, you stopped sharing, yeah. I think
sharing,
it'd probably be better if you did the slides, because I'm just going to, like I say, I've never ever used Zoom before. It's way out of my comfort zone, and we're not even supposed to use it. So I'm hoping that, and I've had a lot of problems because my computer got hacked because I downloaded something that let in a bug. So as I say,
that's fine. Okay, so are you all right with that, Emma?
Yes. Are we continuing at 1:15? Or are we having a break?
No, we said 20 past. We just
20 past. Okay, so okay.
We broke at 10 past. So at 20 past, we'll start with Megan, and then it will be Simon. Have you had any luck with Shri at all?
Yes, sorry, that's who I was on the phone to, so I didn't hear that we've gone on to a break. So unfortunately, he's got 4 patients left, so he won't be able to make it today. He sends his appointment.
That's fine. I'll get Narain maybe to comment on that. On Narain, are you with us? Is he still with us, Narain? Or is he gone? Narain, Haid and Ram was Caesar applications for trust appointed doctors or non-trainees, and Megan has kindly agreed to talk to us and explain the process and hopefully give us tips and hints on how to make it easier and more successful. Megan is the head of Caesar and policy at the Joint Committee on Surgical Training. Thank you very much, Megan.
Hi. So I think Emma's going to show my slides for me. So, I mean, the first slide, move on to the second slide, I think, Emma, thank you. So, everything that I'm going to talk about is actually there on the JCST Caesar part of the website, and that includes our own JCST advice for applicants, but also links to the GMC website for things like the specialty specific guidance, the curriculum, and the certification guidance. Next slide, please. So the standard for Caesar is equivalence to the curriculum that's in place at the time that you apply. So at the moment, the curriculum that has been approved by the GMC that is in place is actually the new 2021 curriculum, because they approved that in November 2020. So in theory, you ought to be making your application against that curriculum. However, that would be completely unfeasible, because as Caesar applicants, you would be applying under a curriculum that no trainees had started using yet. So what the GMC have said is that between now and the 1st of August 2023, you can decide whether to apply under the current curriculum or the new 2021 curriculum. And I'll talk a little bit about the 2021 curriculum further on. So the standard is equivalence to a CCT, which is equivalent to the CCT curriculum. And that means that you have to show evidence currently that not only did you obtain all the competencies, but you're actually maintaining them. And for that reason, the evaluation will focus on the 6 years prior to your application. Now, it's not 6 years prior to your application because of the length of training. It's actually 6 years because anything after that is deemed by the GMC to not be actually current. And as you probably know, you make your application directly to the GMC. They go through a big long evidence gathering and verification process. They then send it to the JCST for an evaluation. We have to have it evaluated by at least 2 people who are on the relevant SAC. We then send that back to the GMC, and the GMC use that to form their decision, and then ultimately the GMC issue your decision. So that's the way it works. So next slide, please. So before applying, you need to read through the GMC guidance, and you need to read through the specialty specific guidance, which is on the GMC website. And I'm going to talk a bit more about this in the next slide. You also need to refer to the CCT curriculum in place and the certification guidelines, which are on the JCST website. And again, all of this information is on the JCSTC as a part of the website. And again, I'll talk a little bit more about it in a moment. The other thing that you really need to do is to find, sort of in inverted commas, a supervisor, I suppose, in the context of this particular meeting, a mentor or a critical friend who can actually look through the evidence actually with you and have a look at sort of what might be missing. And you should really sort of do this at the start of the evidence gathering process, so that you can have a look and then you can see if there are any gaps in the evidence, and then you can work out what it is that you need to do to actually you know, to actually sort of rectify that. And you could even set it out as part of a learning agreement or part of a personal development plan. I mean, obviously, you can always contact the CSER team at JCST, and you can contact the GMC. But I mean, if you're contacting us, the CSER team at JCST, have a think about what it is that you want to sort of ask about, and be reasonably specific, because actually just to say, well, I'm going to apply for CSER, can you just tell me all about it? You know, we could be there forever. So next slide, please. So really, really important, and it's probably, well, that and the curriculum are the most important documents that you need to look at. So really, really important is the specialty specific guidance. So there's one for each specialty, and there's one under the current curriculum, and there's one under the 2021 curriculum. And this is hosted on the GMC's website. And basically it sets out everything that you need to provide, and it also sets out the format in which you need to provide it. And it will also go into details about, you know, how many, how much, etc. And it's also important because the whole application process and the application form, in inverted commas, actually follows the specialty specific guidance, and the GMC will also use it as a checklist to check against to see whether you've provided the appropriate evidence. So it's really, really important that you use this document and that you use the advice within it. You need to look at, obviously, the appropriate curriculum document for your specialty, and I've already talked about, you've got a choice of 2 at the moment. The certification guidelines, these are relevant if you are applying under the current curriculum, and they are hosted on the JCST website, and basically they give a shortened version of exactly what you need to provide. So it'll set out sort of what you need to provide in terms of skills and experience, sort of, so PBAs, indicative numbers, procedures, etc. But it also sets out what you need to provide in terms of research, audit, management in the NHS, teaching, training and assessing. And these guidelines were created, they're the guidelines for CCT. If you're applying under the new curriculum, the guidelines have been actually incorporated into the 2021 curriculum. And so what you need to look at is it's section 5.4 of the 2021 curriculum, together with annexes 3 and 4. And again, all of this information is available on the JCST website. Next slide, please. So, your application, or the evaluation of your application, is divided up into the 4 domains of good medical practice. So domain 1 is knowledge, skills and experience, and you should provide 75% of the evidence that you're providing. That should go towards this. Domain 2 is safety and quality, and 20% of the bundle, 20% of the information that you're providing should go for that. And then domain 3 is communication and teamwork, and domain 4 is maintaining trust. And that should cover 5% divided between both of those. So next slide, please. So domain 1, so this is what you're providing 75% of the evidence for. So we break it down further into knowledge, skills and experience, research, CPD, teaching, training and assessing, and keeping clear and legible records. Next slide, please. So just going into a little bit more detail about some of those categories. So the first thing is knowledge. So the test of knowledge that's set out in the curriculum is the FRCS Cardiothoracic, and it's the JCIE version of the exam. If you have any other sort of exam, or if you don't have that exam, then you are going to have to provide a portfolio of evidence which shows that you meet all the outcomes from that exam. Now, so far, we've not found another exam on its own which is equivalent, because no other exam is based and templated exactly on the curriculum, and that includes the JSCFE exam, which is sometimes called the International FRCS. The JSCFE exam isn't far from demonstrating knowledge across the curriculum, but you would need to provide some further information. And again, the specialty specific guidance goes into that details. The European board exams, they are not equivalent, and generally speaking, you would have to provide an awful lot of extra information along with those if that was what you were trying to do. And you need to actually sort of perform like a mapping exercise. So you need to say what pieces of knowledge show what pieces from the exam or from the curriculum. So it's a really big, it's a really sort of big job. So it's just something to bear in mind. So next slide, please. So logbooks and consolidation sheets. So we want to see the 6 years prior to your application. We want consolidation sheets, so by operation group and by indicative procedure. Again, the specialty specific guidance goes into detail about exactly what it must look like, but we suggest that you use the e-logbook, and if you don't use the e-logbook, at least try and use the e-logbook format. Next slide, please. So you also need to provide evidence of competency, and essentially that's WBA's, work-based assessments. So I don't think that cardiothoracic surgery has any numbers WBAs. I mean, you certainly don't have to do the 40 a year or whatever that was required from trainees, but you should provide evidence of competency for all the main areas. The WBAs themselves, they should not be retrospective, so they hold no value really at all, and they should contain feedback, and they should contain your own reflection, and sort of block markings and tick box exercises don't really make for very good pieces of evidence. And again, the specialty specific guidance will set that out. So next slide, please. Okay, so the other areas, the certification guidelines, or section 5.4 of the curriculum, will tell you sort of how much. So research, those will tell you exactly exactly how many publications, how many presentations you need to present, and will also say that you need to provide a good clinical practice in research course and a research evidence of research methodologies. CPD, that's ATLS if it's required for cardiothoracic surgery, any other sort of mandatory training courses, and also management in the NHS. So management in the NHS isn't just about management and leadership. You also need to have something that addresses the structures within the NHS, things like sort of like funding, commissioning, etc., etc. Sometimes these courses are combined with a leadership and management course, which is fine, and sometimes people have to do it as separate courses. Now, we don't give, we can't recommend one course after another, but what we do say is if you send in the details of the the details of the course and the details of the training, and then we can have a look if it does sort of fit into the appropriate categories. You need to provide evidence of teaching and assessment, and that includes, very importantly, feedback, structured feedback from the people who've been taught, and things like lecture slides so that we can see how you teach. You also need a training the trainer course or equivalent, and that's obviously something which covers things like sort of teaching methodology and that sort of thing. And then finally, with domain 1, there is a category keeping clear and legible records, and the evidence for that is usually you provide referral letters, which, to be honest, you'll be providing anyway at other areas, further on. So next slide, please. So domain 2, which is safety and quality. So the first thing here is audit, and you just need to look at the certification guidelines for cardiothoracic surgery, and it's however many audits are required there, but there will invariably be the requirement for at least one of those audits to have gone into a closed loop. And you need to sort of submit evidence that tells us about your role in the audit. So your role in the audit must be quite clear. The other thing that we want to see in domain 2 is evidence of governance, and we're looking here for sort of evidence of regular attendance and involvement in things like MDTs, M&M meetings and governance meetings. It's not enough to provide a letter from your trust to say that you've attended. I mean, things like actual minutes which show, or agendas which show that you've actually done something, you've given a presentation or you've taken part in a discussion. And I mean, if you've actually chaired one of those meetings, then that's a good example of leadership skills which you can use under domain 3. We're also looking to see that you've got a role that shows that you're involved with the management side of the hospital or trust. So, I mean, some of the things that we see are things like that you've been responsible for rota management, or you've been a representative on a committee, or been involved in a specific working party. But the thing is that you need to make clear what your actual role is in that, what you actually did. So just copies of a rota wouldn't help, but obviously sort of like emails or whatever that show your involvement, that is very sort of helpful. So Then appraisal. So we say at least 3 full cycles of appraisal. Now, I do understand that this is problematic at the moment because of COVID, and that some trusts have been carrying on doing appraisals and some haven't. But I mean, provide as much as you can. And I mean, what we want to see is the appraisal, you know, plus the PDP, and then the next cycle of appraisal, which shows that you've carried out the things in the personal development plan. So the next thing here is safety, and that is covered by all of those mandatory trust courses that you do. So just provide evidence of those. So that's, you know, the infection control, child protection, all of those mandatory courses. So you've probably all got those. And then finally, own health. And there's not really very much that we can say there. I mean, if you've got vaccination certificates, that's fine. But usually that is something that we can take from your references that say that you're in sort of good health. So next slide, please. So domain 3, which is about communication, partnership, and teamwork. So, I mean, all of this sort of, so with this, what we want to see is obviously letters between you and colleagues, referral letters, patient surveys, multi-source feedback. But we also need to see that you've been leading projects and chairing meetings. So we want sort of wider evidence than that of just leading an audit. But if you've provided evidence for the governance criteria of meetings that you've chaired or other projects that you've instigated, then that will do. So, I mean, one piece of evidence could actually could cover sort of like more than one area. And also what we want to see here is a leadership course, which could be part and parcel of the management in the NHS course, or it may well be a separate leadership course, but it's just important that you do have one. So next slide, please. Okay, so domain 4 is basically about maintaining trust. So again, it's a lot of the evidence that you've already provided. So, you know, sort of letters between you and colleagues, you know, sort of thank yous from patients, appraisal, your actual structured reports. They want to see evidence of probity, but to be honest, that usually just comes from the structured reports and references that will have been provided. So, I mean, it's and you have probably provided all of this information for earlier sort of categories. So, next slide, please. So, before you actually submit your application, this is like it's a little checklist, and I think that the presentation can be circulated. So so that's fine. So what I would say is, sorry, I can't actually see the slide because some other bit of my screen is in front of it. So just bear with me. Sorry about this. Yeah, final check before submission. So first of all, if you're submitting alternative evidence to the FRCS, have you shown how your evidence maps to the curriculum? Have you provided things like the syllabus and the syllabus for those particular exams? Have you provided enough details about those? In terms of skills and experience, have you provided the right amount of procedures? Have you provided the right amount of work-based assessments? With research, again, have you provided the right amounts? And do you also have a research methodology course or a good clinical practice in research? With teaching and training, you know, sort of like, does your training course cover the curriculum requirements? So if it's not the usual training the trainer course, if you can send in, you know, the details of the course. Have you remembered to provide evidence of your teaching slides? Have you remembered to provide evidence of the people that you have taught feedback? I mean, in audit, have you provided the appropriate numbers? And also, is it clear sort of what your role was in the audit? And then with governance, again, you know, do you have a course that not just shows leadership but covers management aspects of the NHS structure? And again, I mean, if it's not really clear, then send a copy of the course programme. So next slide, please. So what happens next? So if your application is not successful, then what will happen is that you will be given a series of detailed recommendations, which we try to set out sort of like a shopping list in a way, and sort of break it down as much as possible. And what you have is you have 12 months in which to fulfill those recommendations. So it's not like you have to make a whole application all over again. And they may be very, very small recommendations. I mean, it may literally be do a training the trainer course or provide one more thing. So you've got up to 12 months to do that. If you miss that deadline, then actually what you would have to do is make a whole new application. And of course, I mean, the curriculum could change by then or whatever. You can appeal the decision. You can have a written appeal or an oral appeal. You don't have to go through the review process first, but it's probably the best idea is to do that. Sort of oral appeals, well, both, I mean, they're heard by a GMC panel, which is chaired by somebody who's legally qualified. The GMC will have their own solicitors and will have their own witnesses, and you can bring along your solicitor or barrister and your own witnesses, and they typically go on for about 3 days. All in all, it's quite a grueling process. Next slide, please. So I said I would talk to you about the new curricula. So very briefly, because as I say, you can find all of this information on the JCSTCs, a part of the website. But the GMC have required that all curricula become outcomes based, and they contain shared content between all specialties, and that's not just surgical specialties. So these include the general skills which all doctors need to have, and those are the GMC's generic professional capabilities, or GPCs. Now, there are 9 GPCs, and this applies to all specialties, so whether it's cardiothoracic surgery, psychiatry, sort of whatever. But the GPCs include professional values and behaviours, professional knowledge, capabilities in safeguarding vulnerable groups. So for each of the capabilities, there are descriptors, and these are contained in your new curricula, and again, the specialty specific guidance under the new curricula. They're outcomes based, and these outcomes are meant to be what's needed to carry out all the specific day-to-day tasks undertaken by a consultant surgeon. And JCST has called these capabilities in practice, or SIPs. Now, there are 5 shared SIPs, which are manages an outpatient clinic, manages the unselected emergency take, manages ward rounds and the ongoing care of inpatients, manages an operating list, and manages multidisciplinary working. But there are also 2 specialty-specific SIPs for cardiothoracic surgery, and they are manages patients within the critical care area and assesses surgical outcomes both at personal and unit level. The generic parts of the curriculum that are now the same across all surgical specialties are things like research, teaching and training, management in the NHS, audit. So each specialty up until the new curriculum actually did different things for all of those, but now they're all the same. The other thing to say about the new curriculum for cardiothoracic surgery is that because service needs relate to providing either cardiac or thoracic surgeons rather than cardiothoracic surgeons, you'll start with a common stem of cardiothoracic surgery, but you'll proceed down a more cardiac based path or a more thoracic based path. And again, this is gone into in full detail in the curriculum and the specialty specific guidance. Now, there's one other thing. I mean, in terms of providing evidence of the GPCs and the SIPs, The big piece of evidence for trainees is something called the multiple consultant report. Now, this does not lend itself very well to people who are not in training. So we've developed something we've developed a multiple consultant report for CSER. It's not within ISCP, but you can download it from the JCST website, and all the details about how to fill it in, who fills it in, etc., is on there. I have not gone into great detail about it today because I think you wanted some more general sort of hints and tips, and it's, you know, it take quite a long time to go into, but you can find all the information there, and it is there. So next slide, please. So this is just a slide of useful addresses. It's telling you where the GMC applications website is, where the specialty specific guidance is, where the certification guidance are. And the last bit is my email, which has actually changed recently because I actually got hacked, which was very unfortunate. So my email address is m.wilson@jcst.org. So that's it. So any questions?
Thank you very much, Megan. Very exhaustive list of things that people have to submit. Any questions in the, do you have any idea about the numbers? Great to have you, and I'm sure this was helpful for anybody who's thinking about applying. So I think we will move to our final speaker, and we, last but not least, we have our president talking to us today, and we are grateful for Simon to actually join us, because I know he's been busy today and he's had other meetings to attend. But thank you very much, Simon, for talking to us about the support of the cardiothoracic surgical workforce by SCTS.
Thank you. Can you hear me first of all?
Perfect.
Good. And can you see that first slide?
Yes, we can.
Well, that's a good start. Thank you very much. Good. Mahmood, thank you very much. Thank you for organising and chairing this course. Welcome to all of you who've registered and have joined. This is really important that you're there. You're part of our specialty, you're part of our community, and we want to make it better and fairer, and this is why I'm delighted to give this this presentation. I'll try and move on slides. Just let me, sorry guys. Sometimes you lose your mouse, so it's all a bit difficult. There we go. So this quote is from Benjamin Franklin, one of the founders of the United States of America, and it was Narain who brought it to my attention, and that is saying that justice will not be served until those who are unaffected are as outraged as those who are. So here I sit before you, a white male president who has been on a journey himself, and certainly in the last year, working with Narain and the team, I think I am on the verge of being as outraged as those who are, but I wouldn't pretend to be, because I haven't been through what the people who've suffered from lack of equality and diversity. But I'm trying, and I hope future presidents and future leaders in society will make the same efforts to be as outraged and make the change, make the difference that's necessary. Just briefly, where has our culture in medicine come from? Where's the culture in SCTS come from? I think in the 1980s, medical school admissions were mainly from middle-class schools. It was mainly white, and it used to be majority male, although that's changed. And those prejudices or lack of opportunities went into surgical training. So quite often the junior surgical cohorts were dominated by men, and often by white men as well. and that reflected a culture in the United Kingdom. And it's a bit upsetting when you see TV series like Life on Mars, and it reminds you what life was like just 40 years ago. And for me, I just looked through my fingers and embarrassed about how things used to be, chauvinistic, prejudiced, and we've been on a journey since then, and certainly in the society that it was a very, when I joined the executive in 2005, it was all male and it was mainly white, and I'm pleased to say that things have progressed appropriately. So where are we now? I think medical school admissions there's much more encouragement to all schools and all backgrounds to apply and to be admitted. And that isn't just people from school anymore, but it's people with degrees and other life experiences. So that's more diversity. And equally, the entry to surgical training is more diverse. So in our specialty now, we have 50% of NTNs who are now women, and the BME proportion is going up appropriately as well. We can still do better. And that reflects the culture in the United Kingdom, where there is becoming more diversity and more acceptance. But as I said, we can still do better. For our SCTS virtual annual meeting in May, we met, the organisers and the leaders met in Edinburgh to be a hub so that we can organise the virtual meeting. And for instance, I was delighted, I was the one leader who was a white male, and Richard Steen was the other white male who came to organise the audio-visual for us. But there is more diversity in our specialty at those leadership positions. And I'm pleased we're making progress. It is good to see. So what are we doing? Now, I think these next slides are words, and they are words on a screen, they're words in our policies, and they are words coming from my mouth. What really matters is that all these words, that we change the way colleagues think, we change the decisions they make, and we change the way people behave. That is success. Writing policies and talking is paving the way for success, but success is changing the way people behave. So how do we plan to make that happen in our specialty? Well, we want to ensure that SCTS, all SCTS policy and documentation reflect our position on equality and diversity and inclusion, and also that's attributable to unconscious bias. And we want to make that happen, with more diversity and equality and inclusion by increasing the opportunities and providing support for career progression for women in cardiothoracic surgery through networking events and the Women in Cardiothoracic Surgery Mentorship Programme. And we want an SCTS Women in Cardiothoracic Surgery working group that we've just created to develop these opportunities. And that's part of today's faculty and background to this event today. And that moves us on to the same ethos for trust-appointed doctors, that we want to increase the opportunities and provide support for career progression to trust-appointed doctors. And that's through the Trust-Appointed Doctors Mentorship Programme today and further events, and further the enhancing education programme for trust-appointed doctors. Now, Shree's not able to join us today to talk about that, and at the end of this talk, I'm hoping Narain can update you all on how we're making more equality for trust-appointed doctors and SCTS education. I've talked about, or just mentioned, that medical students and people in medical school, and Aman Kuna, thoracic surgeon in Papworth, has been incredibly proactive and successful in engaging, and he's already started increasing the opportunities to encourage those from all backgrounds, and that's including ethnicity, gender, socioeconomic class, to consider cardiothoracic surgery as a career. And that, as I said, has been done through a national student work experience programme. Within our Circle of Leadership, we're commissioning articles for the Bulletin and SCTS website from those who faced issues related to equality and diversity and how to overcome those challenges. I've just read a great article in the Royal College of Surgeons England Bulletin, and it's from one of the senior female surgeons at Cardiff, Sue Hill, and it's about her experience as a senior surgeon on council and the sexual harassment she's had. It's awful to read, and it's just one example of the challenges that colleagues have had to face. And that's why we have to influence people to behave differently and change the way they behave. So we're encouraging appropriate representation of women and from those of a diverse background in positions of responsibility within the SCTS. I sense, and I keep cross-checking this sense, I sense that no one wants positive discrimination. Everybody wants appointments on merit, but it's encouraging everyone with capability to apply so that we can get that, make those appointments and get that diversity. We're setting up the SCTS Equality, Diversity and Inclusion Working Group. We've appointed the chair, Indu de Glurka, who's a cardiac surgeon in Cardiff. And she's just led the Equality and Diversity Survey for the SCTS, and we've completed the first round. And the plan is, I think, that in 2 years we'll complete that we'll repeat that survey and see if we're making a difference, see if things are changing, see if attitudes are changing, seeing if people are experiencing the same barriers. And I think it's important for all of us in all of our working lives that we challenge professionally and politely any actions, words, behaviours that contradict our philosophy of inclusion, equality and diversity. I think for me, the commonest one is when people refer to surgeons, they refer to him. That's just one example where you can just politely say, they're not always men. You know, it's getting rid of those stereotypes, it's getting rid of those subtle barriers and prejudices that come into our everyday working lives. So just Narain is Honorary Secretary. He is a pleasure to work with, but he has absolutely led this agenda in the last year. I've learned so much from him on this topic. And Narain, I think you've making me more and more outraged. So thank you very much. And the next acknowledgement, and almost an apology really, and it's to all colleagues who've had to overcome barriers, to tolerate poor behaviours, who've had to develop coping strategies, and who've seen opportunities go to others. We will do better, and we must do better. So thank you, Mahmood. I'll stop there. And happy to take questions.
Absolutely fantastic. Thank you very much, Simon. This is a very good talk to finish on the day, but I hope that there will be some questions to you as our president. This is the opportunity of everybody on the course. There's a comment here. This is one of the best, if not the best courses, discussions I've had attended from SCTS, a refreshing leap and breakthrough. I think that will catapult those hardworking people in our specialty forward and instigate changes in positive direction for trust-appointed doctors and women. This is leadership we hear about a lot, but sometimes don't feel or see. Thank you all. Thank you for all the speakers. So it is appreciated that the SCTS has been engaged in this topic of mentorship of the women as well as the trust appointed doctors groups. And I'm sure we will see more and more of that coming through as it has been taken seriously by SCTS leadership. So thank you, Simon, for leading the agenda as well, with Narain obviously playing a big part. Narain, do you want to update us on leveling the playing field by SCTS education, and how is that progressing?
Yes, so Shri sends his apologies. Clinical duties have overrun. Just to reiterate some comments that I made earlier, the SCTS recognises the importance of education, and it recognises the importance of education for all practitioners that are delivering care to patients undergoing cardiothoracic surgery. We've made great strides in what we are delivering for the NTN, nationally appointed trainees, and we understand and recognise the difference in the education that we deliver to the trust appointed doctors. And so over the past 12, 18 months, we have and will continue to make steps to redress that balance. So this year, there are going to be 3 specific courses for trust appointed doctors, 2-day course, the cadaveric course, and a professional development course. In January, there's going to be a specific course to help with CSER and Article 14 application. But on top of that, we recognise that we deliver some very good high-quality courses to the nationally appointed trainees, and access to those courses will be given to trust-appointed doctors. We've done through application to make sure that people are attending courses at the appropriate level, but we understand that it is important for us to bring on the educational resources we give to trust-appointed doctors who, as I said earlier, deliver a huge amount of the service and the delivery of care given to patients undergoing cardiothoracic surgery. In addition, there's the fellowships that we've talked about before, and we are working on different resources to make sure that we can continue giving trust-appointed doctors opportunities to progress both in clinical skills, but leadership, management, research, and such like. So just to stress, as I said, the importance that we put on those educational resources, and that to try and redress the balance between the 2 groups. So on top of that, we've just launched our new SCTS website, where there'll be a plethora of educational resources available, both in terms of videos as well as documents that both nationally appointed and trust appointed doctors can access. So just to stress that we know that there is a difference, and we are making big steps and strides to address that. So
thank you very much, Narain. Another comment from Joe. Thanks, Simon. A refreshing and welcome change in attitude. I still vividly remember one of your predecessors telling me non-NTNs are rota fodder. If you don't like it, leave. We won't ask you to name names, Joe. It's all right. But yes, certainly the attitudes have changed. And as you can see, there is active steps to try and improve the situation. I'll take Emma and then Simon. Emma, you have your hand up. Emma, do you want to?
Yes, I just wanted to follow on from Narain, actually, to use this as an opportunity to let you know that the applications for trust appointed doctors to attend the ST7A revision and Viva course for the FRCS exam is now live on our website, and the deadline for applications is the 30th of July. And as well as the fellowships, the final INSQ final fellowships of this year have also been advertised. They will be available on the website by the end of the day. So I just thought I'd use the opportunity to let you guys know. Thank you, Mahmood.
Excellent. Thank you, Emma. Simon?
Just an explanation and an apology about this unlevel playing field, that the inequality that developed in SCTS education. There used to be no education provided, and a company came along with an amazing offer of money to kickstart a whole education program. And it was stipulated that to do that, it was for NTNs only. And it's been developed really well. And as a specialty, we were very proud, and the success rate in the exam went up. And we just got in a culture of looking at the exam pass rate and saying, oh, isn't that good? The NTNs are all passing. And now you stop and reflect and think about it. It's embarrassing, because actually we were giving top class education to our NTNs, and our members who are trust appointed doctors didn't have access to that education, and their success in the exam was less. So that's an explanation and a really sincere apology that that's developed, and in retrospect it was wrong, but we're putting it right now as quickly as we can. And as I said with Megan's presentation about CSER, we want all members to enjoy their profession, and we want all of you to succeed. And if you're out there and enjoying cardiothoracic surgery and you're successful and you're professional, we want you to enjoy it. We want you to pass the exam. We want you to get through your CSER. So thank you, Mahmood.
Thank you, Simon. Zahid, do you have your hand up?
Thanks, Mahmood. And thanks, Simon and Narain, for taking the trust-appointed doctors' issues forward. And I reassure all of the participants today, and also who are on the trust-appointed doctors, that from SCTS platform, the barriers are getting less and less, and also as Simon and Narain mentioned, that we're giving as much as opportunities for trust-appointed doctors onwards. So I hope, and I will say that all of my, colleagues as well as SCTS member will take that opportunity forwards, and make that the trust-appointed doctors will get good opportunities. And as Simon and Narain mentioned, in terms of FRCS exam and others, they will do as well as the other counterparts. Thank you.
Thanks very much.
Can I just add to what Zahid said?
Yes, please. Yes, Ram.
Just
go
say
ahead.
that it's important to become an SCTS member, and we'd strongly encourage every one of the trust-appointed doctors on here, and to encourage the colleagues within the department to do so as well, please.
Thank you very much for that. There's no other comments or questions. It remains to just me to thank Emma sincerely for all her hard work in organizing this and getting it to this stage. So thank you very much, Emma, for all your work and efforts.
Absolutely.
And I do wish to thank my co-course directors, Narain and Sham, and Shri. Unfortunately, he couldn't be with us. And I'm grateful to all the speakers for giving their time and energy to join us today and making this a very successful mentoring course, which I hope will be repeated again for people who have missed it, but it will be recorded and people can access that resource, I think, which will go on the website. But there will be other groups that we will be targeting, hopefully within our cardiothoracic community with the mentorship scheme. And this is something that will continue to grow and develop and allow everybody to achieve their potential and continued success. Thank you very much, everybody, for attending and for staying the course of the course and lasting this long. And I wish you all the best of luck in the future. Many thanks for everybody.
Thanks, Mahmood. Thank you for running a fantastic course.
Yeah, thank you, Shyam. Thank you, Mahmood.
Thank you.
Thanks, Mahmood. Thank you.
What Mohammed said is, since Simon and Narain